Which part do you go?
Are you saying this is still hold, right?
Come on. So no rush. We're just gonna upload this to Facebook.
You still learn something.
That's pretty fun.
Easy. We should be good to go. Great. So we'll wait until everyone's in, and then I'm gonna head off and do mine.
Yeah.
Thanks so much.
No worries.
Good luck. Yeah, good. Are you prepared? Thank you. I heard that you had these drops last year. So you got this.
Well, you know, studying versus explaining things is a bit different. Yeah. All right, guys. I'll be starting very soon. So all of you find your seats and I'll begin. Thank you. So my name is Ethan and I'm one of the third years who'll be giving you a lecture on lower limb MSK. So I hope you guys enjoy this presentation. Okay, so some of the objectives are to really revise the key aspects of lower limb anatomy and focus on, in particular, exam relevant material. Yep, thanks guys. And then in general, I'll try to structure it such that I'll put up some questions for you to try answering it. And then after that, I'll give the theory after. Okay. So just some general tips about revising any MSK just focus on the different components, so bones and joints, muscles, nerves, and vessels. And whenever you're in doubt, like look at the name, see what see what it says that it means. So like flexor hallucis longus flexes the first toe of the foot. Okay, so I'll begin by covering hip and thigh. So just a pop quiz. What's A? Yep, good. Iliac crest. Next, just shout it out, guys. ACEs, good. C? Yeah, is the greater trochanter. D is? Yeah, that's right. Obturator foramen. And E? Pubic symphysis. And F? Yeah, it's the anterior inferior iliac bone. It's not really important anyway. Next, what's A? So you're looking at the lateral view of the pelvis here. So it's the inguinal ligament. B, what's B? Yeah, it's what we call the acetabulum. So it's, it's like a cup that contains the hip joint here. C? Yeah, that's right, pieces. And D? So it's complex because there's the two ligaments. So that one's the sacrotuberous because it's going from the sacrum to the tubercle of the ischium. And then E is the sacrospinous, that's right. And F is the what you sit on, basically, ischial tuberosity. Great. Okay, so have you seen this question before? So it's your classic examination finding. So can you, okay, so right gluteus medius, I heard. Does everyone agree with that? Yeah, that's right. So essentially it's, Trendelenburg sign is essentially the drop in the non-weight bearing hips. So in that case, the pelvis tilted downward on the unsupported left side. So it means the right gluteus medius is weak. Yeah. So essentially you can see here, it's supplied by the superior gluteal nerve. And when they walk, they tend to have like a compensatory lean to the injured side, and they have this sort of like lurching movement. Yeah. Causes, actually the most common cause is not really the nerve injury, but it's RA or OA. So because of pain, there's a disused atrophy of the muscle. But of course, superior gluteal nerve is what we're looking for, and there are a few other things as well. Sciatic foramen, so you can see it's divided into two components, the greater and lesser. And in the greater, you've got the superior gluteal nerve that goes out from there, and the inferior gluteal nerve that goes below the piriformis. So the piriformis divides it into two parts, yeah? Yeah, and then the inferior, you've got these nerves as well. Great. Okay, so where would be the best place to insert a central line into the femoral vein? So this is about landmarks. So do you remember the femoral canal and what? Okay, so the answer is slightly medial to the mid-inguinal point. And the reason why is because, so it's important to differentiate the mid-inguinal ligament and the mid-inguinal point. So mid-inguinal ligament, as you can see here, is where you find the femoral nerve. So the inguinal ligament goes from the aces to the pubic tubercle, whereas the mid-inguinal point is between the aces and the pubic symphysis. So that's the landmark for the femoral artery. So in this case, medial to the mid-inguinal point means slightly medial to the femoral artery. So if you remember the navel, so from lateral to medial, nerve, artery, vein, empty space, and then your lacunar ligament. So just remember that. An elderly woman was found to have a hernia sac in the right femoral triangle. So the key thing is, okay, so what type of nerve was compressed by this? So firstly, what sort of hernia is this? Do we know? Femoral, yeah. And so which nerve would be compressed by it? No. Is the obturator nerve. So it's coming more medial. Yeah. Okay, which of the following structures would be immediately lateral to the hernial sac as it passes deep to the inguinal ligament? So it's the femoral vein. Okay, so I think, yeah. Okay, next one is acute bowel obstruction from a strangulated hernia. So what does a strangulated hernia indicate? And it's just below the inguinal ligament and lateral to the pubic tubercle. So where's that? So I think, yeah, the previous one was not femoral hernia. It was inguinal, sorry. So this one is, so when you say below the inguinal ligament and lateral to the tubercle, that's actually a femoral hernia. And if you remember, femoral hernia is most likely to strangulate because it's got a very tight femoral ring. Yeah. So it's the femoral canal by the femoral ring. Yeah. And then the site most appropriate for femoral vein puncture. So we were sort of covering that before. So there's the midpoint of the mid-inguinal point, right, is the artery. So if you're thinking about the vein, it's slightly medial to that. So yeah, the answer is A. So if you remember, that's what I was explaining before. And I guess you can also think of the borders, but that's not really as high yield. The main thing is to think of this. Regarding femoral canal, so as you can see, it's a very tight canal, and you've got the medial border, the lacunar ligament, the lateral border as the femoral vein, because it's NAVEL, and the E is the empty space. And so typically during a femoral hernia, there's a real high risk of strangulation. So typically, the other thing is it's often in women because, well, in males, you typically look at more inguinal hernias because there's the, you've got the vas deferens, that's passing through. But in females, it's typically the femoral hernias. And because of the tight borders, there's a high risk of strangulation. And so how you treat it is by cutting this lacunar ligament. But what this diagram is showing here is that sometimes you have an aberrant obturator artery that can be present. And so when you cut it, you can actually damage that and cause bleeding. So there's something to take note of. Okay, key parts of the femur. What's A? So A is pointing to that. It's the greater trochanter, yeah. And B, if that's a greater, that's the lesser, that's right. And then C, so this is what we call, so it's a certain line that muscle attaches to, so it's the linea aspera. Yeah. Okay, so another question. So a female presents to emergency department after a fall, and you notice some abnormal positioning of the limb. So what sort of position would a dislocated femoral hip be in? Do you remember? Okay, so the answer is posterior, superior, and internally rotated. I can see that you guys are not really that familiar with that, but I'll cover that in more detail. So as you can see, during dislocation of the hip, the leg is typically turned inwards like that. So so typically it will be more internally rotated, superior above the acetabulum, and internally rotated, as you can see here. If you have any questions, feel free to ask. Yeah. And so in a posterior dislocation of the hip, typically it's the sciatic nerve that's damaged. Yeah. So this often happens in dashboard injuries. So when you're in a very fast motor vehicle accident, your knee hits the dashboard, and then that can lead to damage of the sciatic nerve, which just runs behind the hip joint. Okay, a 90-year-old female fell out of bed and experienced severe pain in her right hip and upper thigh. So a 90-year-old female, you know that she's probably osteoporotic. And when she falls, you can see her right lower limb was shortened and externally rotated. So what sort of fracture are we seeing here? Just call out if you think you know. Okay, so the answer is a fractured neck of femur. So yeah, common things are common, guys. So the others would not lead to the similar leg deformity mentioned here. Yeah. So in this, so if you do have a femoral neck fracture, which part would be most likely have its blood supply cut off? So what happens when you have a femoral fracture? What happens to the hip? What are you most worried about? Yep, that's right. Avascular necrosis of the head of femur. So that's this point. So it's G. So all these questions that I'm putting up are from past papers that we were given. So yeah. 78-year-old female comes in after a fall. You suspect a problem and order an X-ray, which shows a fracture. After a closer look at this type of fracture, you're concerned about the necrosis to the femoral head. So which type of fracture has most likely occurred and which artery is disrupted? So do you know which one is most important? So both the medial and lateral supply the head of the femur, but which one's more important? And is it intracapsular or intertrochanteric? So it's intracapsular. So it's because what happens is, I'll show you the blood supply. So you can see that the blood supply to the head of the femur is by 3 different vessels. So there's the medial circumflex, which is a branch of the profunda femoris. And it sends these capsular branches that go underneath through the capsule. So whenever you damage the capsule, you can damage these blood vessels. And there's also another artery that comes in from the top through the ligament of the head of the femur. So that's the acetabular branch of the obturator artery. However, usually it's insufficient to supply the head, and often with age, it tends to fibrose, so you don't get enough supply. So really the key supply is really the medial circumflex femoral artery. There's also a bit of lateral, but it's mainly medial. Okay, so #NOF, so fracture of neck of femur. So intracapsular fractures are typically worse, as what was mentioned. And yeah, This is what we covered in the question. So a male equestrian was thrown off his horse and he experienced a snap and severe pain in his right thigh. Soon he becomes pale and hypertensive with a rapid pulse and a swollen thigh. I think it's supposed to say hypotensive. I'll correct that. You diagnose a fractured midshaft of femur. So what sort of vessel would be severed in that case? So which vessel like travels closest to the femur and is most likely to be damaged? Just call out, guys. B, D, E. I guess they all sound similar. Yeah, it's profundifermis, that's right. Good job, guys. So as you can see here, the profundifermis is very close to the femur, and it sends these perforating branches that go around through the small hiatus in the adductor magnus. So yeah, typically that's what you're most worried about. Technically, you can damage the femoral artery as well, but that's less common. In Monash land, it's basically the profundifermis. When you have when this happens, the case you were seeing there is a case of compartment syndrome. So how you remember it is by the 6 Ps, which you may be familiar with. And typically, I think I've listed it according to like the order in which it happens, I believe. So paralysis is like the most serious. And that's essentially what's happening is all the blood is swelling inside the muscle and it's cutting off the blood supply to it. So it leads to muscle infarction. And the only way to treat it is to do a fasciotomy. So cutting the fascia of the muscle to open it up so it relieves the pressure inside. Okay, pes anserinus. I don't know whether Quentin Fogg's still teaching you guys, but it's one of his favorite things. So how you remember it is say grace before T. So from superior to inferior. So S, G, T. So sartorius, gracilis, and semitendinosus. And typically the clinical thing to worry about is the pes anserine bursitis, which is basically presents as shown here. Okay, so now we've covered the thigh. Now we're going to the knee and the leg. So with the patella, it's the largest sesamoid bone and it resides in the quadriceps tendon itself. And dislocations typically occur laterally. So what happens is the quadriceps femoris, its line of pull is actually slightly lateral. So that gives a predisposition to a lateral dislocation. And the only thing that protects it is really the vastus medialis part of the quadriceps, which is the most important protective factor. So post-injury, typically you want to focus on building up the strength of that muscle. There are also other things which protect against lateral dislocation. So you can see the lateral femoral condyle is a bit higher than the medial. So that also protects it partially. And then these are just ligamentous structures as well. But basically, what you need to remember is there might be a sudden blow to the leg or sudden contraction of the quadriceps, and that leads to a dislocation of the patella as shown here. So another pop quiz, what's A? This is what you examine in the knee exam. Yeah, the tibial tuberosity. B. So which one's medial, which one's lateral? Yeah, so the fibula is always lateral, and then the tibia is medial. And then D is a soleal line, so yeah, not that important. Okay, so a passenger from a bus crash has a horizontal 2 cm long, 1 cm deep laceration to the leg, and it passes posteriorly from the insertion of the biceps femoris tendon. So which structure is probably severed? So biceps femoris, if you remember, is one of the muscles of the hamstrings. So it's the common fibula. So the biceps femoris attaches on the lateral side of your knee. So if it's posteriorly from the insertion, then that will likely hit around the area of the head of your fibula, which will hit your common fibular nerve. Okay, so a man has an abnormal gait and his left foot is dragging on the ground. And he keeps trying to lift his knee higher to try to prevent this. So what are we seeing here first? What syndrome are we seeing? Yeah, I think I heard someone say foot drop. And what nerve is important in preventing foot drop? So yeah, it's the common fibular nerve. Common things are common. So tibialis anterior, if you remember, is the muscle that helps you dorsiflex your foot. And so the common fibular nerve is important in supplying that. Yeah. So if you remember, the common fibular nerve breaks up into two sections. So one innervates the anterior leg muscles and one supplies the lateral leg muscles. So, but the most important one is really the tibialis anterior. So in a case of that, you wouldn't be able to do any heel strike. Another type of fracture in fibular fractures are the fracture of lateral malleolus. So that typically happens when you have an eversion. And as you can see, there's the Weber scale, which some of you are familiar with. So basically it's A, B, C from bottom to up to the top. And C is most serious because you get the least stability. Okay, so a male slips on the stairs while going to work and he presents with pain in the right knee. And the GP performs the varus stress test. So what does the varus stress test assess? So, yep, I heard some people say lateral collateral ligament. That's right. So varus, if you remember, is, yeah, so varus versus valgus. So it's essentially trying to stress it that way by pulling your tibia more medially. Okay, the lateral meniscus of the knee joint. Okay, this one's a bit more niche and detailed. So the answer for this is it receives an attachment from the popliteus. Okay. So a footballer was tackled and felt a sudden pain in his flexed left knee. And then when the tibia was grasped, there was excessive backward sliding of it on the femur. So what sort of ligament was ruptured here? So if it's sliding backwards, remember, that's your posterior drawer test. So it's testing your posterior cruciate ligament. Okay, another person you suspect has a ruptured ACL. So the ACL of the knee joint, which one is this? So blends with a fibrous capsule. No, not really. Has a rich blood supply. No, ligaments are avascular, but have, well, not avascular, but they have very little blood supply, but they have a lot of nerve supply. So they are painful when they're damaged, but they heal very well. And so the answer is really is within a sleeve of the synovial membrane. So there was also an associated torn medial ligament. And so the medial ligament is it's attached to the medial meniscus, right? So that's why you have your unhappy triad. A footballer has an opponent fall across his weight-bearing extended left knee and he feels a sharp pain. On examination, there was swelling with marked tenderness just below the tip of the lateral epicondyle of the femur. So there was excessive mobility. So firstly, what sort of ligament was damaged here? So lateral epicondyle is the fibular collateral ligament. That's right. So now there's excessive mobility with minimal accompanying pain. So what does that indicate regarding the ligament? So it's totally ruptured, right? Because if it's sprained, there will be limited movement, but there'll be lots of pain. Good. Okay, so knee joint ligaments, the key things are you've got your medial and your lateral. So what was tested before was the popliteal tendon. So the key thing is the popliteal tendon separates the lateral meniscus from the lateral collateral ligament. So it's not directly attached, whereas we know the medial one is fused to the MCL. And that's why when you have the unhappy triad, when the MCL is damaged, it also damages the meniscus. Regarding collateral ligaments, I think the main thing is remembering that the MCL is typically, I guess, more easily damaged because it's less mobile. And yeah, you just need to know what force would damage it. So a lateral blow to your extended knee would damage the MCL, whereas a medial blow to the knee would damage the lateral ligament. And with cruciate ligaments, with ACL, it prevents hyperextension, whereas with PCL, it's typically not that easily damaged, but in a dashboard injury that can occur. And also twisting of the knee also will damage your ACL. And so the easiest way to think of how the PCL works is think of walking downstairs. So if I'm walking down, the weight-bearing flex knee at the back is being supported by the PCL as you're doing the eccentric contraction. So a few other structures. So this from Netters. A is, yep, that's right. I heard someone say the PCL. So that this one must be the ACL. And C. So remember fibula is lateral. So it's the lateral meniscus. And then D is medial. Wait. Oh, sorry. E. Okay, yeah. Okay, that's the medial meniscus. And then F. So this is the medial collateral ligament or the tibial collateral ligament. And then this is what I was talking about before. It's the popliteal tendon. So it separates the lateral meniscus from the lateral collateral ligament. And now this is an open view of the knee. So you can see here, this one is the, so just think of anterior here. This is posterior, so it's the PCL. This one's the ACL. This one is the, so remember the medial one is more C-shaped, the lateral one's more O-shaped. So it's the medial meniscus, this is the lateral meniscus. And then this is the MCL, because you can see it's attaching to the medial meniscus. And then this is the popliteal tendon, if you remember. Wait, no, this is the popliteal tendon, sorry. This is the fibular collateral ligament. So the popliteal tendon separates it. And then DH in front, if you remember, that's the, you've got the patella and then you've got the quadriceps tendon that's attaching to patellar ligament. The patellar ligament is just below the patella and it's part of the quadriceps tendon. So what's the unhappy triad again? You guys should be able to do this in your sleep. So ACL, MCL, and medial meniscus. Very good. So often it's by a lateral valgus force to the knee. And it all happens because it's connected physically. Meniscal injuries, if you remember, the outside of the meniscus here is supplied by, has good blood supply, whereas the inside is not really well supplied. So typically when you have meniscal injuries, the outside can heal, but the inside will not. So what happens is if you've got pieces of the meniscus that break off, that can form loose bodies, and these survive in the synovial cavity because the synovial fluid will nourish them and keep them alive. But what will happen is when your joint is moving, it may sometimes catch the joint, and that leads to locking of your joint. And so you test the meniscus with the McMurray's test or the meniscal groin test, as you've learned. And how to treat it is to do arthroscopic surgery, so opening up the joint and removing any damaged parts of the meniscus. So bursitis, essentially there are two types. There's the housemaid's knee. So to differentiate it, you just think of how the person kneels. So in a clergyman, imagine they're like kneeling at one of the kneeling pews in church, for example, and then that will affect the area slightly below. So it's the infrapatellar bursitis. So you can see this part. Whereas if you've got housemaid's knee, they're sort of leaning forward, trying to like wash or clean the floor. So that will affect this bursa here, the prepatellar bursa. And then if you know what Baker's cyst is, or some of you may not know, it's actually just an outpouching of the synovial membrane into the posterior area of your knee. So that's your that's in the popliteal fossa. Yeah. Okay, so the popliteal artery is it superficially located or is it most deep? Yep, it's deep, that's right. It's located between the popliteal vein and the tibial nerve. If we said it was deep, then it's not between there. Yeah. Is a direct continuation of the profunda femoris artery. So profunda femoris, no, yes, no? No, it's from the femoral artery. And then it's directly related to the femur in some of its course. That's the right answer. So that's why you can actually palpate it when you palpate for the popliteal pulse, because whenever you're palpating, you're pressing it against a bony structure. So that's why you can palpate it. And obviously, it's not the fractured neck of fibula. That's a common fibular nerve. Yeah. Which of the following is most likely to be endangered by dislocated knee joints? So just think of which nerves travel around there. Or it may not be a nerve. Actually, in this case, it's not a nerve. So it's what we were talking about before, the popliteal artery. So it's very close to the bone. So if it dislocates, it's easily damaged. Yeah. Okay, so yeah, you can see popliteal fossa. Deeper structure is the artery, then the vein, then the nerve. And so the clinical relevant thing is, I guess, a popliteal aneurysm. It can compress the tibial nerve, and that can lead to weakness in your calf muscles. And therefore, plantar flexion will be affected and can lead to paresthesias in the sensory supply. Okay, regarding tibial fractures, so proximal tibia, typically damaged by falls from height. Shaft of tibia, I think that's the important one to focus on. It damages the popliteal artery. And typically you can see here, it's often in like skiing or running on hard surfaces or motor vehicle accidents. And distal tibia, that is typically through ankle sprains, so your inversion injuries. And that can also lead to an avulsion injury of the medial malleolus, which is where the tendon attaches. Okay, tibiofibular joint. So the key thing to remember here is that there's a proximal one, a distal one. The proximal one is a synovial joint. The distal one is a syndesmosis. Because of the interosseous membrane, when you have a fracture of the tibia, it can often affect the fibula as well because of the transfer of force. Okay, now to the ankle and foot, which I think most of us by this time will not have done much study on. Okay, so someone's jogging and suddenly there was tenderness in the dorsum of the foot, and you can see that the shaft of the bone was in line with the lateral cuneiform bone. So which metatarsal was fractured? So someone call out. Okay, you're thinking third? Yeah, that's right. So you can see over here, the metatarsal that's fractured most often is actually the second one, because it's actually wedged in between the two cuneiform heads, and it's also the narrowest and the longest. So that's most often damaged. But in that case, we were saying it was in front of the lateral cuneiform bone. So that's the third one. So with this, you just need to sort of remember where the bones are. Yeah. But I wouldn't be, yeah. Okay. So with regards to the bones, the hind foot, you've got the talus, the calcaneus. The talus is just underneath, and it sits inside this mortise, where there's the tibia and fibula. And then below that, you've got the calcaneus, which is your heel bone. And then you've got the navicular just in front, cuboid, 3 cuneiforms, and then your metatarsals and phalanges. And sometimes there's sesamoid bones present, which are variable. So with the ankle joint, with the joints of the foot, so I was already talking about the tibiofibular joint, which is the one, which is the mortise I was talking about. Then there is the subtalar joint, which is between the talus and the calcaneus here. And then there's the talocalcaneonavicular joint, which is also what they call, I think, the subtalar joint. So it's this bone, and this bone articulating together. And then you've got the mid-tarsal joint, which is between the calcaneus and the cuboid, and that allows mid-foot rotation. And then there are all the other joints, which are, I guess, not as important. It's like, just think of like what happens in the hand. It's quite similar. Okay, so someone had an inversion injury, and there was marked tenderness at the base of the 5th metatarsal bone. So the base of the 5th metatarsal is where you've got the insertion of the peroneus brevis. So you've got another case of an inversion injury, and there was a sudden sharp pain. So there was marked tenderness below the tip of the lateral malleolus. And there was pain rather than excessive mobility. So you know what type of sprain it is. So the deltoid, if you remember, is the medial. So this one is the lateral ligament we're talking about. And the most likely one to be sprained is the anterior first. Yeah. So as you can see here, this is the lateral ligament. So it's got 3 different bands. There's the anterior, the calcaneofibular, and the posterior talofibular. And it's sprained in that order. So the anterior goes first, then the calcaneofibular, and then the posterior one. I know because I've sprained my ankle a few times. I can tell I've damaged my anterior already, and I'm up to this one. But anyway, eversion injuries wise, that's the medial deltoid ligament, and it's very strong. It's got 4 different parts, and typically when you have sprains of that, it breaks in one piece. But it's very rarely damaged. Okay, so someone asked me about the arches of the foot, so I thought I'd put this in as well. So you can see that there are supports to it, including the spring ligament or the plantar calcaneonavicular ligament. That's the key thing because as you can see, this is the arch here, and this is the apex of the arch. So that is the most important ligament that supports it. You've also got the short and long plantar ligaments that support it, as well as the plantar aponeurosis. And as for muscle tendons, you can see you have the tibialis anterior and posterior tendons that help support part of it, and the flexor hallucis longus actually moves along the whole length of the arch and giving it support. So you can see that these other two tendons, the fibularis longus and the tibialis anterior, they provide almost like a stirrup. So imagine like on a horse, and you've got this which will help pull it up, keep it up. Yeah. So I'm not sure how much yield that has, but in case you wanted to know, that's what it is. Okay, so how do you remember the tarsal tunnel? The easiest way is to think of this mnemonic here. So Tom, Dick, and very nervous Harry. So from anterior to posterior. So tibialis posterior, flexor digitorum longus, artery, vein, nerve, and then flexor hallucis longus. And as you know, tarsal tunnel syndrome occurs similar to carpal tunnel syndrome. So you can test it with Tinel's test as well. And it typically affects joggers because that's where it's most strained. Regarding a few other conditions, I've just listed here for your reference, so you can study a bit later. And I mentioned the stress fractures here, as you can see. Okay, so now neurovasculature and muscles in the last 17 minutes. Okay, so muscles of the buttock, I'm just going to list these. I'm not going to go into them in detail, but it's for your reference. So there are 10 of the buttock, as you can see here. And the key things to remember is the inferior gluteal nerve supplies the gluteus maximus. The superior gluteal nerve supplies the gluteus medius and minimus, as well as the tensor fascia lata, which forms with the gluteus maximus as the IT band that goes down the lateral side of your thigh. And then you've got all these other muscles, which are external rotators of the hip, and the nerves that supply them are essentially very simple to remember. It's just nerve to piriformis, nerve to this, etc. Okay, so you can see the hip and the thigh has 3 different compartments. So there's the anterior, the posterior, and the adductor muscle. So the whole list is here. So I think with muscles, the key thing is to just remember which nerve supplies which compartment. And in general, you'll be able to remember the supply. And then you should also know roughly the function of each. So the quadriceps femoris, so in the anterior compartment, it's mainly the femoral nerve. And then the main muscle here is the quadriceps femoris. Okay. For the sartorius, how you remember it is it helps you sit cross-legged because sartorius is, tailor, so they had to sit cross-legged in order to do their work. So that's how you remember what it does. It crosses 2 joints, and it's actually one of the longest muscles in the body. The pectineus, and then there's this extra one, which I think is not that important, but just for your info, it helps pull your suprapatellar bursa superiorly during your knee extension, so it doesn't get caught. Obturator nerve, if you remember, it goes through the obturator foramen, so that's pretty medial, so it supplies the adductor muscles, except the hamstring part of the adductor magnus. So adductor magnus has the adductor and the hamstring parts. So just think the hamstring is supplied by the tibial nerve because the tibial nerve is important for the posterior compartment. And so that supplies the hamstring part, which is essentially, is almost like part of the hamstrings anyway. And then the adductor part is by the obturator nerve. So the tibial nerve, if you remember, it supplies the 3 hamstring muscles, so semimembranosus, tendinosus, and the biceps femoris, except for the long hip. So there are these, exceptions that I'm not sure whether they might test you on. It would be a bit harsh, but just for you to remember. Okay, as for the leg, you just think of 3 compartments again. So anterior, lateral, and posterior. So in anterior, you've got the common fibula. And you remember I was saying it divides into 2 branches. So the deep branch goes to the anterior compartment. The superficial branch goes to the lateral compartment and supplies the everters. And then you've got the posterior one, which is the tibial nerve. And that supplies the tricapsulae. So that how you remember that is, well, I guess it's easy to remember it as a group. So gastrocnemius, plantaris, and soleus. And then you've got the popliteus. So popliteus because, you know, it pops open unlocks the knee joint. So that's how you remember it. And then there are a few other deep muscles which are not as important. Okay, regarding the foot, it's pretty low yield, but I've listed it here for you to study in your own time. Okay, so, this is also a pretty harsh question, but it's basically the first plantar interossei. So you just, yeah, there's basically, I've listed here, you've got the medial plantar nerve that supplies all of these, and then the lateral plantar nerve, which supplies everything else. So it's similar to your median nerve and your ulnar nerve in your hand. So as you can see, it comes through the tarsal tunnel. It divides into 2 parts. So there's the medial and the lateral plantar nerves, and they supply almost everything in the sole of the foot. Myotomes-wise, there are various ways of remembering it. Like some people have a wrap. I tend to just remember it as like in pairs. So as I go hip flexion, it's 2, 3. And then I just think that the first pair, it doesn't overlap L4, whereas the second one overlaps L4. So it's 2, 3, and 5, 5, 1, 2, 2, 3, 4, and then 4, 5, 1. And then the rest I remember by reflexes. So you can see 1, 2 is ankle, 3, 4 is knee, 5, 6 is biceps, 7, 8 is triceps. So I just think, okay, knee is 3, 4. So that's knee extension. And then therefore knee flexion is plus another 2. I mean, like the next 2 down. And then ankle reflex is S1 and 2, as I was saying. So therefore the other one is 4, 5. Yeah. And then inversion and eversion is just 5 S1, which is sort of in between the ankle ones. So I sort of do it in order. But yeah, there are different ways of remembering. Dermatomes wise, yeah, just remember, I often like thinking of it as like what happens if you are urinary incontinence. So imagine everything just flowing down. So it starts at L1, L2, L3, then L4, it hits the medial part first and then goes to the lateral part. And then same thing with fecally incontinent. So it starts at S5 and then it sort of goes down to S4, S3, and then S2 at the back. And then, yeah, and there are basically key parts which you can test in your exam. Yeah. Okay, another passenger from the crash had a jagged 8 cm laceration of the skin on the dorsum of the foot along the line of the 3rd toe. So a nerve block would be most appropriate at, so along the line of the 3rd toe on the dorsum of the foot. So you just need to think of which nerve supplies that, and that is the superficial fibular nerve. So if you remember, superficial fibula supplies most of the dorsum of the foot, and then the deep fibular nerve supplies the area between the 1st and 2nd toe. They like testing that, apparently. So yeah, this is what I was saying before. So you see the superficial supplies most of the dorsum, and then the deep supplies this little bit here. Remember that, guys. Yeah. Okay, then there's the sural nerve and the saphenous nerve. So how I remember it is the saphenous accompanies the great saphenous vein. So if you remember, this great saphenous vein is on the medial side. It goes anterior to the medial malleolus and goes up. So that's saphenous. And then the sural nerve will accompany the other one, which is a small saphenous vein on the lateral side. Okay, so IM injection. So where do you do the injection? So it's the upper outer quadrant. Just always remember that. And which nerve are you trying to avoid? Sciatic nerve, that's right. So that is L4 to S3. That's good. So yeah, as you can see here, this part doesn't have any nerves that you can damage there. And the reason why IM injections are good in the buttock is because you can give a bigger volume of fluid, basically. Whereas in the deltoid, you can't really give that much. Okay, so I don't know whether I should go through this. Okay, but yeah, it's not very high yield, but how I remember it is I twice get leftovers on Fridays. So I twice, so it's ilio-hypogastric, ilio-inguinal. Get is genitofemoral. Leftovers is lateral femoral cutaneous nerve. On is obturator, F is femoral. And then I just think 2 from 1. So 2 from the first one. So if you remember, the lumbar plexus is L1 to L5. So 2 from the first one, sorry, L1 to L4. So 2 from the first one is 2 from 1. So it's 2 from L1. So L1 supplies ilio-hypogastric and ilio-inguinal. Then 2 from 2. So that means there's L1 and L2 that will supply genitofemoral, and then L2 and L3 that will supply lateral femoral cutaneous nerve. And then 2 from 3, which is the last 2 essentially. So 2, 3, 4, 2, 3, 4. Yeah. There's actually a video that explains this quite well. So how you remember sacral plexus is SIPS. So you just draw it out like this. So the S, superior gluteal, you got 4, 5, 1, 5, 1, 2, 1, 2, 3, 2, 3, 4. And then sciatic is just going across like this. 4, 5, 1, 2, 3. So this is an easy way to remember it. But as for I don't know how high yield it is, but if you want to really memorize it, which is what I did for my second year exams, this is what I did. And there are a few other minor branches of the sacral plexus for you to know. I've put things in more detail in the slides that I'll give you later. Okay, the key things are the nerve entrapments here. So the lateral femoral cutaneous nerve, it passes under the inguinal ligament, under the lateral attachment of that. So it can typically get entrapped and cause sort of pain on the lateral thigh area. Tibial nerve, we were talking about, the tarsal tunnel syndrome. Medial plantar nerve, often when you're jogging, that can compress it. And sciatic nerve under the piriformis. So you remember piriformis divides the sciatic foramen, the superior part of the sciatic foramen, into 2 parts. So typically the sciatic nerve goes under that, so it can be compressed there. And then the superior gluteal is on the top of the piriformis, and it can be also entrapped there. So just sort of being aware of which areas, which nerves can be entrapped at which. As for arterial supply, I sort of think of it as sort of like have a sort of framework from starting from the aorta going distally. So initially you got your abdominal aorta, it goes into your 2 common iliacs, got your internal iliac, and the only one which supplies the lower limb is really the obturator artery that goes through the obturator foramen. And as for the external iliac, it becomes a femoral artery when it passes under the inguinal ligament, and then it gives off this profunda femoris, and then it divides into the superficial femoral artery. So the profunda femoris is the deep one. The superficial one is the SFA. And then that becomes the popliteal artery as it curves around the back of your, at the popliteal fossa. And then it divides into the anterior tibial artery and the posterior tibial artery. So anterior tibial artery becomes the dorsalis pedis, which is what you palpate. And the posterior tibial artery divides into the medial and lateral plantar arteries. Okay, so another question. There was a glass fragment embedded posterior to the lateral malleolus of the right thigh, of the right ankle, sorry. So think of what's on the lateral malleolus. What do we think, guys? So it's the short saphenous vein. So yeah, these are really like buzzword things. You just need to remember which vein goes where. The lesser saphenous vein is accompanied by which nerve? So I was sort of talking about that before. Sorry, it should be just the saphenous vein, not the lesser saphenous vein. Apologize for that. Wait, sorry, this is wrong. It should say lesser, oh, well, I guess small saphenous vein. I guess it's a variant on it, so it's not wrong. Technically, it's the sural nerve. So you remember the saphenous nerve accompanies the great saphenous vein. The lesser one accompanies the sural nerve. And there's another glass fragment, this time in the anterior border of the medial malleolus, medial to the tendon of the tibialis anterior. So in this case, it's the great saphenous vein. So sometimes, like maybe even in the exam, you might just look at your ankle and see, okay, I see a vein in front, so that's probably the one, Yeah, the cheat sheet. Venous drainage-wise, how you remember it, the deep veins follow the arteries, so you don't really need to re-memorize it again. For superficial veins, you've got just the two key ones, the great saphenous and the small saphenous. So the great saphenous, as you can see here, it goes anterior to the medial malleolus, goes all the way up, and then it drains on the medial side of the leg, and then it drains into the femoral vein just before it goes into inguinal ligament. As for the small saphenous vein, it goes on the lateral side behind the lateral malleolus. It goes up all the way to the popliteal fossa, as you can see here, and then it drains into the popliteal vein. And then you've got a lot of other like perforating branches that these superficial veins connect with the deep veins. And essentially when you have weak, like incompetency of these valves, the blood can sort of backlog into the superficial venous system, and that leads to varicose veins. Okay, so there's a list of all the vessel lacerations that you can get for your own study. And that's it. I'll be releasing to you guys a more detailed presentation. So the one that you have has like 70 something. This one has 138. So I've also included like a few extra ones that I wasn't able to cover today, but hopefully it will help you as you study. Hey, I don't know. How do you think I could improve? I felt like people went.
I don't think it's your fault. I think lower limb is like most people didn't study it, and it's like pretty tough. I think it's a pretty good job. But, I don't know how.
They have a lot of content anyway in the slides, so they can study.
Yeah, it's pretty hard because you don't know to do a lot of content.
Okay, see you.
Alright, so hi everyone. Hey guys. All right, hey guys. Yeah, we'll just get started now. Yeah, so I'm William. I'm one of the third years placed at Dandenong this year. So for anyone out there who got SES, I can definitely vouch for Dandenong. It's really good. And then next year I'll be at Frankston. So for anyone at Central, I might see you there. So today I'll be covering cardiology, mainly for VIA. So I think in terms of year one content, cardiology is probably the highest yield. So let's get started. So just going through the breakdown for VIA. So as you can see, there's like a lot of ethics, law, HKS stuff. So you definitely have to learn it. Especially for end of year, there's probably 20 marks of ethics and law. So I don't know if you guys have the one-page summary documents of law and ethics. They're really good. And then you definitely need to learn all the theme 2 stuff. So like sensitivity, specificity, like positive predictive value, all of those things. And then the things I've highlighted in yellow are the things that will be covered for cardiology. So there'll be like a couple of marks in each of these. And then you've got heme, immuno, medicine of the mind. They're all like a few marks each. Yep, so just a few acknowledgements. And this, yeah, so these are the things I'll be trying to cover today, but because there's a lot of content and I've only got an hour, I'll try to go through the higher yield content. So we'll just start off with a few questions. So does anyone want to answer this, or I'll have to pick someone? Georgia? Do you want to answer? Okay, so a 40-year-old man collapses at home from an acute myocardial infarction. He's found to have an arrhythmia relating to the SA node. Which of the coronary arteries is most likely to be involved? Sorry? Yeah, it's B. So yeah, the right coronary artery. Everything else is from the left, so you can just kind of rule it out. So question 2, do you want to pick someone else to answer? Yep, so the right side of the sternum, second intercostal space. So a bit of clean skills. Yep, aortic. Which of the, do you want to pick someone to answer the next question? Yeah, so which of the following does the main azygos vein drain into? Yep, SVC. Yeah, so it just drains into SVC. And do you want to pick someone to answer the next question? Yeah, so which of the following supplies the pericardium? C, yeah, phrenic nerve. So it supplies the somatic sensation, so that's when you get pain. Do you want to pick someone to answer the next question? So what is the mechanism of action of digoxin? Yeah, so positive inotropic effect. So it just means that it increases how much blood gets pumped out. I'll go through all of this in more detail later. Just trying to see which topics you guys need help with. So do you want to pick someone else? Sorry? Yeah, hypertrophy. Yeah, so yeah, just letting you guys know, some of these, they might seem very similar to past VIA questions. So yeah. Do you want to pick someone else to answer the next question? So during which phase do the coronary arteries fill, and what drug will prolong the filling time? Sorry? Yeah, diastole and beta blockers. And all right, so clinical skills. Do you want to pick someone? All right, Jun, what do you think this one is? Yep, Osler's nose. What about this one? Yep. What about this one? Yeah, and then this one. Yeah. Yeah, sometimes they like to just give you a picture and then ask you what it is. Do you want to pick someone for the next question? Oh yeah, this is a bit of maths. Do you have an answer? Yep, C. So yeah, I'll go through the formula in more detail later, but ejection fraction equals stroke volume over end diastolic. And then you can work it out with the formula. It's just like a lot of maths. This is another maths question. You might skip it. And this is also a maths question. Do you want to pick someone else? Yeah. Yeah, it's E. So when you increase radius by the factor of 3, the flow will increase by the factor of 3 to the power of 4, so that'll be 81. And then do you want to pick someone else for the next question?
I'll pick
Yep, so which of the following occurs in cardiac muscle contraction but not skeletal muscle contraction? Unsure, that's all right. So it's just A. So for cardiac, there has to be calcium entering from outside, which then causes calcium to be released inside. Whereas skeletal, there's action potential from outside that results in calcium. Question 13, do you want to pick someone?
I'll pick Calvin.
So which drug may not be an appropriate treatment for this condition? So first, do you want to tell me what the condition is that you see? There might be a little bit there, but there's something else if you look at this, just this lead. Yeah, AFib. So which one would you not use for AFib? Or like which one's not really related to AFib? I think you don't usually use it for AFib, but it's an antiarrhythmic drug that like can potentially be used. But I think statins is I guess more unrelated to AFib because it's for cholesterol control. And then this is kind of like a third year question, but they can also test it for second year. So do you want to pick someone? Yeah, so 23-year-old IV drug user, a bit of a buzzword there. Fever and shortness of breath, and they've got infective endocarditis. What do you think the most likely diagnosis is? It's pretty much solely based on IV drug user. Oh, pretty close. It's tricuspid regurg. So this is just a buzzword you kind of have to remember. So IV drug users kind of just think of it as the tricuspid valve is the first valve it gets to after they inject and it goes through. And then the bacteria will land there and cause regurg. Okay, so we'll just go through some clin skills. So for year 2 OSCEs, I think for histories, you mostly just go through everything. So you go through your intro, history of presenting a complaint, blah, blah, blah. And then you choose a couple of systems reviews and you go through it. I think for our year, one of the stations, they told us to specifically do renal systems review. So you only do renal. And then one of the other stations, they said, like, do whatever systems you think are relevant. So you had to do, it was like feeling hot and sweaty. So you had to do like endocrine and cardio. So year 2, you don't actually need to know too much, just need to memorize this setup kind of. So we'll go through it. So intro, consent, confidentiality, blah, blah, blah. And then going through history of presenting complaints. So where, when, quality, quantity, all of those. And then past history. So for cardio specifically, you need to ask things like, have you had any past surgeries, like for the heart? Have you had any previous heart attacks or any heart conditions? Do you have high cholesterol, diabetes, hypertension? You pretty much have to ask these for cardio history. And then family history, you have to ask about if you've had any family history of coronary artery disease or any heart attacks in the family. And then for medications and drug history, definitely have to ask about smoking and alcohol. For social history, I like to use the acronym SNAP-W, so smoking, nutrition, alcohol, physical activity, and weight. It usually covers most of the social history things. And then all the risk factors for coronary artery disease, so previous heart attacks, high cholesterol, smoking, high blood pressure. You have to ask all of these for cardio, otherwise like they won't really like you very much when they're doing the marking. Yeah, so just going through the systems review for cardio. So the acronym I use is CDOPS-FAPI. So yeah, so C stands for chest pain. So these are the conditions that could be causing the chest pain that you should kind of think about. So for heart attack, it's usually chest pain radiating to the left jaw or the arm. There might be a bit of sweating and nausea and vomiting. Angina, it's not as severe, and it's only when they exercise and it's usually a dull ache. Aortic dissection, it's like a sudden onset chest pain radiating to the back, and it's like tearing in nature. For pericarditis, it's worse when lying down and you get pleuritic chest pain. And then these are some RESP and GIT conditions. And then the D stands for dyspnea. So it can be from heart failure, heart attack, can be from some respiratory conditions as well. And then when you ask about dyspnea, always ask orthopnea and paroxysmal nocturnal dyspnea. So these are all for heart attack, so you have to ask them. So just ask, does your shortness of breath get worse when you're lying down? If they do, ask how many pillows they sleep on at night. And then also ask about PND. These are all left-sided heart failure signs and symptoms, sorry. And then S is syncope, so that's just fainting. You can get it from heart failure, aortic stenosis, arrhythmias, and you can also get it from strokes and seizures. And then the F is fatigue. It's pretty much not a very specific symptom, so it can be like from anything. And then ankle swelling is right-sided heart failure, so you should always ask that. And then palpitations is mainly from arrhythmias. Intermittent claudication, so pain in your calves when you walk, that's mostly for peripheral vascular disease. So yeah, if you get any kind of cardio history, definitely go through all of these. And then if they want you to do other systems, you should kind of touch on a bit of RESP and maybe renal. And always ask about fever and weight loss in like every history, because it's really important to rule out cancer and infection. So just going through the cardiovascular exam. So for year 2 OSCEs, you literally just go through every single step, and like you're not really looking for anything, to be honest. You just like show them the action that you're doing. So in the STEM, they'll tell you what not to do, but this is pretty much everything for the cardio exam. So general appearance, I like to do posture, body habitus, pain, aids, deformities, and then looking specifically for cardio signs. So cachexia, weight loss, congenital conditions like Marfan's and Turner's, and then dyspnea, fatigue, and then looking at the hands. So you look for so this is the mnemonic thing I use. So you look for Janeway lesions so I start off palmar side, look for Janeway lesions, look for Osler nodes. These are all for infective endocarditis. And then I look for clubbing of the fingers. And then so I do CCC all together because they're all of the nails and around there. So you check for clubbing, cyanosis, capillary refill. And then splinter hemorrhages and tar staining are also at the nails as well. So a lot of the signs at the hands are all for infective endocarditis. The rest of them are just for like general heart conditions. And then tar staining is a smoking risk factor, and tendon xanthomata, just to check if you have high cholesterol. So yeah, those are the hands. And then for cardio exam, you have to mention vitals. So you have to say, I'd also like to do pulse and blood pressure. And then you should usually go and do it. And then if they don't want you to do it, they'll actually stop you. So you check for rate and rhythm of pulse, and then say you'll do blood pressure. If you're unlucky, the examiner won't stop you. and then you'll waste like 2 minutes doing blood pressure. So hopefully not. And then for eyes, I use JAKs, so jaundice, anemia, Arcosanellus, Argyll-Robertson, and xanthelasma. To be honest, you don't really need to do Argyll-Robertson, but I think it's good to mention it just so that they can tick it off. Because the U2 OSCE marking criteria, it's just ticking off the things that you've done. So just mention jaundice, anemia, just go through all of them. And then for face, just mention malar flush, which is for mitral stenosis. For the mouth, just checking for central cyanosis, dentition, higher arch palate, which is for Marfan's, and petechiae, which is for infective endocarditis. And then at the neck, it's always good to do carotid pulse. So usually listen to the carotid pulse first, listen for any bruits, and then feel for it, for character and volume, and then do JVP. So make sure you're always standing on the right side of the patient, otherwise they might fail you. And then get them to turn their head to the left and then measure at 45 degrees. This is looking for right-sided heart failure. So then we move on to the precordium and the chest. So inspection, so RRPPSS, so rashes, respiratory distress, checking for any pacemaker or any scars of past surgeries, and any skeletal deformities like funnel chests or kyphosis. And then for palpation, just feel for the apex beat here, and then the thrills, you do it over each of the valvular areas, so mitral, tricuspid, pulmonary, aortic. It's basically just, none of the patients will have them, so you just do the actions. And then the heaves, yeah, you just do the actions. And the heaves, you just go like that and feel it. You won't really feel much though. For auscultation, so this is the order I like to do it in. So MTPA, and then expiration, inspiration, inspiration, expiration. So mitral, start with the bell first, and then listen there. Get them to expire and listen again. And if you want to make it louder, get them to roll onto their left. And then use the diaphragm for the mitral valve again. And then move on to the tricuspid, which is using diaphragm and its inspiration. Pulmonary, it's around here. Second intercostal on the left side. Inspiration, and then aortic. Get them to expire and sit up. And it's second intercostal on the right side. And when you get them to lean forward, you can also check for sacral edema as well, just to save time. And then this is peripheral vascular exam. So just checking for pitting edema. So that'll be heart failure. Peripheral pulses, so checking the femoral. So they won't get you to do femoral. Popliteal, posterior tibial, dorsalis pedis pulses. And then checking for peripheral vascular symptoms. So I don't know, you just have to memorize it. So pallor, capillary returns, peripheral cyanosis, temperature, hair loss. It's just symptoms you get if you don't have enough blood going to your feet or to your legs. And then Achilles tendon xanthomata for high cholesterol. Yeah, so for U2 OSCEs, literally just memorize it and try not to miss anything, because they just, and then also try to look like you're actually looking for something. So try to be like, oh yeah, no tar staining, no clubbing. Don't be like, oh yeah, no clubbing, no tar staining. Actually try and look for it, or pretend you're looking for it, because they will give you marks for that. They can tell if you're not actually looking for anything. Yep, so that's it for clin skills. So embryology, this is really low yield. So I guess in the interest of time, might skip over it. So this is a YouTube video that you can watch if you're keen. It kind of shows you how the heart forms, but it's really low yield. I don't think we had any questions on it for our VIA. Yeah, so this is a summary of how the heart forms. You can kind of read it in your own time. I think if you want to read any of the slides for embryo, this is probably the most important one. So how the foramen ovale forms. Yeah, I'll let you guys read that in your own time. And then fetal circulation. Yep. And then these are some of the congenital abnormalities. It's more fourth year stuff, so I don't think you really need to know it. So just going through anatomy now. So basic anatomy of the heart. You guys probably already know all of this, so we'll go through it quickly. So you have blood in your in your legs and arms, which get drained out via the superior vena cava and the inferior vena cava, and it goes into the right atrium, which then goes into the right ventricle. And this is all deoxygenated blood, so that's why it's blue. And then it goes through into the pulmonary trunk, into the lungs here. And then the lungs will reoxygenate it and add oxygen to it. And then it will come back through the pulmonary arteries, veins, back into the left ventricle, left atrium, and then the left ventricle, and then out through the aorta to the rest of your body. So that's pretty much it for the heart. So the valves, you have two atrioventricular valves. So that's the tricuspid here and the mitral here. So the special thing about these is that they've got chordae tendineae attached to papillary muscles that helps to keep them open. Otherwise, they'll just invert and close. And then we have the semilunar valves, which is the pulmonary valve here and the aortic valve here. They kind of just act like the valves in your veins, so they don't have any chordae tendineae or anything like that. So what the valves do is they just allow for one directional flow. So they won't let the blood flow backwards, pretty much. So coronary artery circulation. So your heart also needs a blood supply. So that's what the coronary arteries are for. So during diastole, so that's when your ventricles are being filled, the blood also helps to fill into the right and left coronary arteries, which then supplies the heart. So this is kind of the picture we have here. So we'll just go through it. So here's the right coronary artery. And if you follow it up here, it supplies the sinoatrial node, yeah. So that was one of the questions we had before. And then it'll go down and go behind the heart, and then it'll supply the posterior part of the heart, so the posterior interventricular branch of the heart. So I think you should know this for VIA. So the posterior interventricular artery is what determines the dominance of the heart. So usually it'll be the right coronary artery that supplies it, and that will usually be the answer. So they might ask you like, I don't know, if the right artery supplies this, which one is dominant, I guess, and it'll just be right side. And then the right coronary artery supplies most of the right side of the heart. Left coronary artery mostly supplies the left side of the heart. And I don't think you need to know it in too much detail. So the mediastinum, so that's all of the middle bit here. It's divided into the superior and inferior mediastinum. So this is divided by the line going through the sternal notch. So that's T4, T5. So the superior, you can kind of visualize it. So the middle mediastinum has your heart, it has all of the neurovasculature for the heart. And then you can picture like the aortic arch going up and then down through the back here. So the superior mediastinum, you know that the ascending and descending aortic arch will go through it. You know that the esophagus will also go down the back here. And there's not really too much important stuff. There's like the vagus nerve, phrenic nerve. I think one of the questions we had last year was which structure is in the anterior mediastinum, and like no one knew, but it's the thymus, and no one really cares about thymus, so I don't know why they asked it, but that's just like a buzzword to remember, I guess. And then the posterior, there's not much. There's like the esophagus, descending aorta. Yeah, so I think just remember the thymus and a bit about what structures are in each of them. So this is a transverse cut of the same plane, so the thoracic plane. So I guess when we get something like this and you don't know what's going on, I guess identify the structures that you know. So we know that this is obviously the lungs. And then because of that, we can see that there's a couple of blood vessels going into the lungs. So it's probably the pulmonary trunk. And then we see these two. It's probably the bronchi because they're also going to the lungs on each side. And then posterior, we have the esophagus here. And then we also have these two red things here. So this is actually the anterior and descending aortic arch. So it kind of arches over and comes down here. So that, like, I guess in case they give you this and ask you to label it, this is the fully labeled one here. This is also structures at the thoracic plane. So bifurcation of trachea, aortic arch, pulmonary trunk bifurcation. Okay, so going through the pericardium now. So this is the layer surrounding the heart. So the outer layer is the fibrous pericardium. So, and then the next layer is the serous pericardium. I don't think it's too important. I think just know that the serous pericardium is divided into parietal and visceral. Parietal is somatic innervation. Visceral is visceral innervation. So when you get pain with pericarditis, it's because of the parietal layer of the serous pericardium. And then in between these two layers, you've got a little space and there's a bit of fluid in there, which allows for movement of the heart. So the supply to the pericardium, we've got the pericardiophrenik arteries. So these ones here, they come off the internal thoracic artery. And same on the other side. And then they also have the pericardiophrenik vein as well. I guess the important thing to know is the phrenic nerve is what supplies the pericardium in terms of somatic like pain innervation. So when you get pericarditis, you get the sharp stabbing pain. It's because of the phrenic nerve. So after the pericardium, we get the, so as you see here, we get the serous pericardium, and then the visceral pericardium is the same as the epicardium, so it's the same thing. And then we have the myocardium here, which is just the muscle layer of the heart. So that's what does all of the pumping of the blood. And it's involuntary, striated synctium, some buzzwords. And then endocardium is just the inner layer, not too important. Just know the myocardium is the muscle layer. So the blood vessels of the heart. So these are the layers of the blood vessels. So we've got the tunica adventitia. So that's just the outside layer, not too important. And then the tunica media. So because it's the middle layer, M media muscle. So it's the muscular layer that kind of constricts and dilates the blood vessel. And then we have the tunica intima, which is the inside endothelial layer. So it's pretty important because the endothelial layer secretes hormones like NO, which help to control the diameter of the blood vessel. So NO would help to dilate the blood vessel. So it kind of controls the flow of blood through the artery and the vein. So arteries, they're known as the pressure reservoir, mainly because of this picture here. So because arteries are quite elastic, during systole, when your ventricle pumps blood out into the rest of the body, 2/3 of the blood actually goes to stretch the artery here, and then 1/3 goes along through. And because of the 2/3 stretching the artery, during diastole, it will kind of like recoil, and then the rest of the blood will go through. So that's why you get constant blood flow, even though during diastole, you're not actually pumping any blood out from the heart. So just going through the cardiac cycle, so ventricular systole is when blood is pumped out from the ventricle into the aorta and then out to the rest of the body. And then diastole is just when the blood is flowing from the atria into the ventricles and filling the ventricles. So valves control directional flow. And then heart sounds. So I guess at the moment we only get heart sounds because every time the valves close, it kind of like snaps shut, and that's why we get the lub-dub. During third year, you'll learn more about like the murmurs, which is because the valves aren't functioning properly, and that's why you get the murmurs. So we'll go through a little bit of that now. So what can happen with the valve is that it can become stenosed, which means it doesn't open properly, or it can become insufficient or undergo regurgitation. So that means it doesn't actually close properly. So whenever that happens, so as you remember, you'll get turbulent flow if it's not smooth flowing. And because you get turbulent flow, so for example, here we have a stenotic valve, and let's say it's not open properly. So because of that, the blood will flow in and then it'll become turbulent flow. And because of that, when you put your steth to that heart valve, you can actually hear like a murmur. And same with the regurgitation. Because it doesn't close properly, some of the blood will leak back out and you'll get a murmur. So this is like a way to remember it. So PAS and PAID. So PAS is pulmonary aortic stenosis, is a systolic murmur. So it means that when the ventricles are contracting, you'll get this murmur. And then PAID is pulmonary aortic regurgitation, diastolic murmur. I don't think it's too important to learn it in second year, but it'll be really important next year. So I think you should kind of learn this just in case they asked you during the VIA. And the mitral and tricuspid is just the opposite of pulmonary and aortic. So for pulmonary and aortic stenosis, it will be mitral and tricuspid regurgitation, both causing systolic murmur. Okay, so for autonomic control of the heart rate. So as you may know, you get sympathetic and parasympathetic innervation of the heart. So sympathetics will innervate all the conducting parts of the heart. So the SA node, the AV node, and it will also supply the ventricles as well. So because it supplies the ventricles, you'll get increased contractility. So that's just how much the heart contracts. And you also get increased heart rate and conduction because it supplies the conducting system. For parasympathetic, it will only supply the conducting system. So it will decrease heart rate and conduction, but it won't affect contractility. So when you exercise, your sympathetics will activate. It will increase contractility, increase heart rate, and this will increase the cardiac output. So a bit of physiology, because you guys already learnt this a lot in first year, I might skip through a lot of it. So just going through the basics again. So the conducting system. So everything starts at the sinoatrial node. So here, like there's always an action potential being started here, just automatically by this node. And it will go down through to the AV node. And there will actually be a delay at the AV node to allow the ventricles enough time to fill. And then we'll go down the left and right branches into the Purkinje fibers to supply the ventricles. So the action potential just goes down here, and then that's what actually allows the heart to contract in unison. So ion channels. So as you may know, the extracellular fluid has more sodium and calcium. Intracellular has more potassium. That's pretty much what you need to know. So when these channels open, so for example, when the sodium and calcium channels open, you'll actually get the sodium and calcium channels going into the intracellular space, and this will result in depolarization. And the same with the other, so same with the potassium. So when it opens, the potassium will go out into the extracellular and you'll get repolarization. So it's pretty important for these things here. So as you can see, for the pacemaker action potential, you have the sodium, so you have a funny channel already open. So this is sodium entering, and because we know that it causes depolarization, it will be going up slowly, and then calcium channel also opens, so it will continue going up, and then another calcium channel opens. So this is the slow L-type calcium channel, which will result in even more depolarization until you reach this point. Once you reach this point, this voltage-gated potassium channel will open, and as you may already know, so potassium results in repolarization, so it will go down. So this is what's actually coming out of the SA node, so this constant action potential. So it'll just keep repeating itself, and that's kind of what determines your heart rate. And here we have the ventricular action potential. So this is what makes the muscle actually contract and pump. So initially it'll be flat and it's not contracting. So this is when it'll be relaxed. And then because of sodium entering, it will depolarize, and then potassium will enter. Potassium will leave, so then it will repolarize again. And then because calcium actually opens here, the calcium will counteract the potassium. So it will result in kind of a plateau because they're balancing each other out. But eventually another potassium channel will open and then it will repolarize again. So, these things are a bit difficult to memorize. So only if you have time, remember them. Otherwise, just know the general concept of it. So sodium and calcium depolarization, and then potassium is repolarization. Okay, so now going through the pacemaking rates. So all of these nodes actually have a pacemaking rate, and they're always giving off an action potential. The SA node is the fastest one, 70 to 80 beats per minute. So this is why it's the primary pacemaker. So think of it kind of like trains all being connected to each other. And the SA node is the first train, and it's going at the fastest speed. So everything else will be following it because they're all connected. And then the AV node is a bit slower, 40 to 60, and the Purkinje fibers are about 15 to 30. So what can go wrong with these? So you can get cardiac arrhythmias. So one of the situations is that, for example, the SA node, it just screws up, so it doesn't work anymore. And because of that, the AV node will have to take over. And because it's only 50 beats per minute, your heart rate will be 50 beats per minute, so it will be pretty slow. A second thing that can happen is just the SA node is screwed up and gives an abnormal impulse. And then you can also get an AV block. So this would be the AV node not working properly, and there's a block there. So then the SA node does its own thing, and the Purkinje fibers will do its own thing. So that's why on the ECG, you get that prolonged, PR interval there, because the AV node is screwed up. And then you can also get ectopic beats. So for example, the Purkinje fibers are just going really fast and it pushes everything else along, and you'll get an arrhythmia there. So the difference between cardiac muscle and skeletal muscle. So we went through this before. Cardiac muscle is just calcium-induced calcium release. So what that means is that calcium from the outside of the heart will enter, and then from outside of the cell will enter, causing more calcium inside to be released. Whereas for skeletal muscle, there will be action potential that causes calcium to be released from the inside. So I think out of this slide, that's the most important thing you need to know. Okay, so here are some of the formula. I think it's good to know it just in case you get some of those maths questions. So blood flow equals to the pressure difference over the resistance. So obviously increase in resistance will decrease flow, and increase in the pressure difference will give you increased blood flow. So as you guys may remember, I guess blood flow only occurs when there's a difference in pressure. So blood will only flow from a high pressure to a low pressure point. So resistance is proportional to length times viscosity over radius to the power 4. So I think the most important thing to know is that the radius is what is the major factor for controlling resistance. So because it's to the power of 4, a small increase in the radius will actually cause a major decrease in the resistance. So just remember that's inversely to the power of 4. And then compliance is just how stretchy your vessel is. So for example, like a balloon will have really high compliance because you can fill it up heaps and there won't actually be a lot of pressure. Whereas like a steel pipe will have really high compliance because you won't be able to fill it with a lot of volume before you get a high pressure. So it's just how stretchy it is basically. So cardiac output, this is how much blood is being pumped out of the heart per minute. So it equals to stroke volumes times heart rate. So stroke volume is the amount of blood being pumped out per beat, and then heart rate is beats per minute. So that's why the formula is there. And then stroke volume, so that's the amount of blood being pumped out per beat. So that equals to the end diastolic volume minus the end systolic volume. So the end diastolic volume, so it's pretty much how much blood is inside the ventricle after all of the filling is done. So that's like the max volume it can have. And then the end systolic volume is the amount after it contracts and pumps everything out. So that's the minimum volume it has. So it's just the difference between the two of them. So now we have the ejection fraction. So it's just the fraction of the stroke volume over the end diastolic. So in like simpler terms, it's just the fraction of how much blood is being pumped out of the total volume of blood. So there are some ways we can increase or decrease cardiac output. So we can either change the heart rate or the stroke volume. So there are two ways you can change the stroke volume. So you can either increase the amount of blood filling into the ventricle, so the end diastolic volume, because you're increasing the end diastolic volume. So pretend this is the ventricle and you're filling it up more. Because of that, it'll stretch the muscle length and then it will contract more. So that's why increasing end diastolic will increase stroke volume. And then calcium is also really important for contractility. So if you increase calcium, it will also contract more. So that's how you can increase cardiac output. So Frank Starling, I guess the only thing you need to know is that increasing the amount of blood in the ventricle will increase the stroke volume. And that's pretty much it, yeah. Second rule of Frank Starling, if there's increase in right-sided blood, there'll be increase. So if there's a lot of blood in the right side, it will go to the left side, and then there'll be a lot of blood in the left side, and that will result in a lot of blood being pumped out of the left side. So like the left and right side will always match up. So if there's too much on the right, it will get pumped out through the left. So that's just the second rule. So contractility or inotropy. So that just means how like strong the contractions are, but it's not based on the end diastolic volume. So contractility is solely based on your calcium and your beta receptors. So just know that sympathetic will increase contractility. That's pretty much what you need to know for that. So the cardiac cycle. So we've got passive filling of the ventricle first. So this is during diastole. So you just have the atrium filling the ventricle and the blood is flowing through. Everything is open. There's no contraction or anything. So because of that, the ECG is silent. And then because of that, we get atrial contraction afterwards. So the reason why the atria contracts is to allow for the filling of the ventricle. So there's still a little bit of blood left in the atrium and it contracts just to allow for more blood to fill the ventricle. So because of the atrial contraction, you get a P wave. So just link atria and P wave together. And then you'll get the QRS complex. So that's when the ventricles contract. So just kind of link those two together. And then you also get the first heart sound. So that's when the AV node closes here. And then afterwards, when the ventricles relax, you'll get the T wave. So that's all you really need to know. And then everything will repeat itself afterwards. And then the second heart sound is just when the atria or pulmonary valve closes. So there's a bit of a summary so that you can learn in your own time. So blood pressure. I guess it's just how much volume is in the blood and how distensible the walls of the blood vessel are or how compliant they are. So here's some more formula. So pulse pressure equals systolic minus diastolic. Mean arterial pressure equals 2/3 diastolic plus 1/3 systolic. I think it's good to memorize them just in case they ask you to do it. So arterioles, I guess the most important thing to know about that is that it's mainly just endothelial cells and some smooth muscle cells, and it's important for controlling diameter of the vessel. So the arterioles are the most important for controlling how much blood flows through. And so when it constricts, you'll get decreased flow. When it dilates, you get increased flow. So local chemical control. So when you exercise, you get a lot of decrease in O2, increase in CO2, and increase in acids and ADP. So your body is pretty smart, so that it knows that when it gets all of these, it needs to increase blood flow to the muscle because you need more when you're exercising. So actually dilate the arterioles to allow more blood flow. Same with reactive hyperemia. So for example, when you're doing the blood pressure cuffs, it will occlude your blood vessel. And then after you take it off, you kind of feel all the blood rushing back through. That's because of reactive hyperemia. And then myogenic response to stretch. So when the blood vessel is stretched, it will automatically try to constrict so that the blood flow through the blood vessel remains constant. So, and then temperature, heat will cause it to dilate, cold will cause it to constrict, basically. So these are good to know, just in case they ask you. And then sympathetics, always know that sympathetic will increase your stroke volume and cardiac output. It will increase your heart rate. So how it does that is it acts on the alpha receptors and the beta receptors. So the beta receptors are in your heart and in your skeletal muscle. So in your heart, it actually causes it to dilate and also contracts more and increases the heart rate. And then the alpha receptors will cause the blood vessels in your smooth muscle to constrict. So sympathetics increase blood pressure as well. And then you have also the other hormones that can affect your blood pressure. So you have dilators and constrictors. So NO is probably the most important dilator to know, and angiotensin is a constrictor. So the endothelial layer. So I guess just know that it's in charge of excreting hormones for vasodilation and constriction. Yeah, that's probably all you need to know. And then veins. So veins have really high compliance, which means that they can fill with like a lot of blood without having high pressure. So because of that, it's the volume reservoir. So it contains most of the blood. And when your sympathetics activate, it kind of constricts the vein and increases the pressure. So why it does that is so that it increases the venous pressure so that the blood from the veins will then go back into the right atrium because blood flows from higher pressure to lower pressure. So if your venous pressure is increased, there'll be more blood flow to the right atrium. Yep, so that pretty much goes through there. So right atrial pressure is, so venous pressure and right atrial pressure is what determines blood flow from the veins into the atria. So if you have a lot of blood in your veins here, you'll have a higher pressure here. So because of the difference between here and the right atrium is increased, more blood will then flow back into the right atria here. So just comparing arterioles and veins. So when you activate your sympathetics, it will constrict both of them pretty much. However, for arterioles, when it constricts, it increases resistance, so there's less blood flow. For veins, however, as we talked about before, even though it increases the pressure, it will actually increase flow because of what we talked about here. So it will increase the pressure so that it will increase flow. So just know that this one decreases flow and this one increases flow. So venous return, we kind of already talked about it. Other factors that help in venous return, so the skeletal muscle pumps. So like the muscles in your calves will help push the blood back up into your heart and the respiratory pump. So whenever you breathe in and out, it also pushes blood back into your heart. So the cardiac function curves. So we'll have a look at the red one here first. So this is a graph between end diastolic volume and cardiac output. So as you may know, so end diastolic volume, if you increase the amount of blood inside your ventricles, it will increase, so it will stretch more and then contract more. So you'll get increased cardiac output. So because of that, you'll get this curve. When you activate your sympathetic system, it will actually increase your contraction. So that's why the curve moves up. When you get heart failure, you're not pumping the blood as well. So the curve will come down. So now we're going to have a look at the black curve here. So this is between right atrial pressure and venous return. So as we talked about before, so if right atrial pressure increases, you'll get so it will have increased resistance from the veins. So because of that, when right atrial pressure increases, you'll actually get decreased venous return. So I think that's the most important thing to know. So yeah, based on these two graphs, that's probably pretty much it. Yeah. So these are some more formula to learn. So yeah, you can learn that in your own time, I think. So, okay, so clinical conditions, probably a bit more important. Yeah, so when you take your cardiovascular histories, you have to ask all of these basically. So, or you don't need to ask if they're a man, but you need to ask like if they have high blood pressure, high cholesterol, diabetes, smoking, all of that. And these are all risk factors for atherosclerosis and heart failure, heart attacks, like every heart condition basically. So high blood pressure, so that's when the blood pressure is over 140 systolic and 90 diastolic. So most blood pressure is actually idiopathic, so we just don't know what's causing it. It's probably genetics. And then we have some other causes, so 10% is secondary, so it could be from pregnancy or renal disease or Conn syndrome. So to treat high blood pressure, we usually do lifestyle factors, so your SNAP-W, so like smoking, nutrition, alcohol, physical activity, all of that. And the most important thing is diet, so reduce salt intake, because salt will increase the amount of fluid in your body, so that will increase the blood pressure. Pharmacological treatment, every time there's a question about like which drug would you give for hypertension, 95% of the time it's ACE. Unless they say that the person doesn't tolerate dry cough, then it'll be ARBs or calcium channel blocker. So it's usually ACE though. So atherosclerosis, so it's just a buildup of cholesterol plaques inside your blood vessels. So we'll go through a bit of the pathology. So when you're around like 20 years old, so you guys now, you'll get a bit of like damage to your endothelial layer, and long-term damage will cause macrophages to come, and then it will also get lipids to also accumulate here, and then eventually you'll form foam cells, you'll get fatty streak, and then the smooth muscle from the media layer will also enter, and eventually you'll get this massive plaque here. So as you can see, it's like blocking the blood vessel here, so not as much blood is going through. It's a progressive condition, takes like decades to form. So some complications from atherosclerosis, so it can cause peripheral vascular disease. So that's just when there's not enough blood flowing to your like peripheries, so like your legs, and stable angina or heart attack, so not enough blood flowing through your coronary arteries. It can also rupture and cause a heart attack as well. Because you have a plaque here, sometimes a bit of it can flick off into your brain or into your heart, so you might get a stroke, might get like kidney infarction, things like that. Yeah, you can also get an aneurysm, which is just a weakening in the wall of the blood vessel. So ischemic heart disease. So it's actually divided into 4 things. So stable angina, unstable angina, NSTEMI, and STEMI. So we'll start with, so these are all like, I guess they're all 4 different things. They're all part of the ischemic heart disease, and they're all quite similar in presentation. So the typical presentation would be central crushing chest pain radiating to the left arm and to the left jaw. You might also get sweating, nausea, vomiting, dyspnea. So the reason why you get this is, so as you can see here, there's a lot of plaque and atherosclerosis in the coronary arteries supplying the heart. So for unstable angina, it will be about 70%, and then for the other ones, it will just keep increasing. So STEMI would be like 90-something%. So stable angina, so stenosis of the coronary arteries. So you'll only get symptoms if it's over 70% occluded. So some of the differentiating factors, so you'll get predictable chest pain. So the patient might be like, oh, every time I exercise, I get the chest pain, so they can predict when it comes on. It will be like a crushing or a dull ache, so not as severe, and it will be aggravated with exercise. It will also be alleviated with rest, and usually it doesn't last too long. We'll have a look at unstable angina now. So this will be increased occlusion, so it'll be like 80-90%, and it'll be chest pain that actually comes on when you're at rest and also at night. So that's why it's different to stable angina. However, there'll be no raised troponin, no ECG changes as well. So going through NSTEMI now, so the occlusion is even greater than before. So because of that, you'll actually get infarction of your heart tissue. So like the inner layer of your heart will actually die. And because the inner layer dies, you'll get the ST depression on ECG. You'll also get raised troponin levels as well. For STEMI, it's ST elevated myocardial infarction. So obviously there'll be ST elevation. So this one is pretty much full occlusion of the artery. You'll get transmural, so the entire thickness of cardiac wall will be dead. So all of that is dead. So you'll get troponin and ST elevation on ECG. So how do we manage heart attacks and ACS? So always do ECG first to confirm it. And then if you suspect it from history and exam, then do serial troponins. So you want to check the changes in troponins. If it's increasing, then you know that they have a heart attack. Other things you can do is echocardiogram. It's pretty much ultrasound of the heart. Coronary angiogram, looking at the arteries around the body and around the heart. So this is how you treat heart attacks. So the acronym is MONASH. So you give them morphine for pain, oxygen if their O2 sats are decreased, nitrates to open up the blood vessels, aspirin, statins, and heparins, so anticoagulation and anti-cholesterol. If it's still not resolved, you can consider PCI. So this is when you stick like a tiny catheter into the blood vessel and then blow up like a balloon inside the blood vessel and open up the blood vessel from inside. You can also do thrombolysis. So that's when you break down the blood clot using medications. If it's really serious, so then you would actually do CABG, so coronary artery bypass graft surgery. So heart failure. So heart failure is pretty much when there's not enough blood supplying the rest of your body and your organs. So I guess some of the main important cause is actually a heart attack. So when you have a heart attack, because of the death of the cardiac muscle, you're actually not pumping as well. So you're not getting blood out of the aorta into the rest of the body as well. So that's why you'll get heart failure. There are also other causes like cardiomyopathy, high blood pressure, valvular diseases. So heart failure, I generally split it into right-sided and left-sided. So we'll think about left-sided first. So if the left side of the heart isn't pumping as well, you'll get fluid overload. So fluid will eventually accumulate and then it will backflow into the lungs here. So because there's a lot of fluid in the lungs now, you'll actually get a cough and you'll be coughing out pink frothy sputum. So that's a buzzword for left heart failure. You'll also get shortness of breath. You'll get orthopnea, P&D as well. So these are all for left heart failure. And then if you get right heart failure, so if the blood isn't pumping enough out of the right ventricle, there'll be fluid accumulating here and it will go back and backflow into the JVP. So that's why you get raised JVP and also into your ankles, into your abdomen. So that's why you get peripheral edema, ascites, and also back into your liver. So hepatomegaly. So I guess that's a good way to remember why the signs and symptoms correlate with the heart failure. How do you manage heart failure? So first you want to investigate whether or not they have heart failure. So BMP, that kind of checks whether the heart is failing, and then chest x-ray, you'll see cardiomegaly as well as echocardiogram. So lifestyle, SNAP-W again. SNAP-W is pretty good for all the cardiac conditions. How do you treat it? So just remember these 3 drugs are for mortality benefit. Loop diuretic, even though it helps with the fluid overload, there's actually no benefit to mortality. So if they ask you a question like which drug has no benefit for mortality, it's always furosemide. It's just for symptomatic management. ACE, beta, and spironolactone all have mortality benefits. So infective endocarditis. So that's just the infection of, I guess, the inner layer of the heart, usually at the valves. So the organisms that can be causing these, it's usually Staph aureus, can be Strep viridans, and also epidermis. So some of the risk factors. So if you have a prosthetic heart valve, if you're IV drug user, dental procedure. So if you see these in the OSCE or in the written exam, always think about infective endocarditis. So some of the signs and symptoms. So symptoms, because it's an infection, you'll get fever, you'll get rigors, you'll get sweats, and you also get loss of weight and fatigue. Some of the signs, so you guys probably know these: Janeway lesions, Osler nodes, new murmur, Roth spots, splinter hemorrhages, all of those. And then, so Janeway lesions, it's on the palms usually, and it's non-tender. Osler nodes are usually painful and they're on the fingertips, so that's how you kind of differentiate the 2 of them. To manage and diagnose it, you have to do an echocardiogram and then do blood cultures. So pericarditis, so that's just inflammation of the pericardium, so the outer sac of the heart. It's usually caused by a viral infection. So on the history, so in an OSCE, it'll be sharp stabbing chest pain. It's pleuritic, so it'll get worse on inspiration and when leaning back, but it'll get better when leaning forward. So on exam, the sign will be pericardial rub. I guess for treatment, you don't really need to know, but just NSAIDs and colchicine. So tamponade it's like an emergency, so you have to treat it immediately with urgent pericardiocentesis. So it's just when you stick a needle into like the second intercostal space and to drain the heart. Beck's triad are some of the signs of tamponade. So if you see words like muffled heart sound, pulsus paradoxus, or raised JVP, always think about tamponade. The reason why you get muffled heart sounds is because it's filled with fluid. So because of the fluid, it's interfering with, I guess, your steth. It's like in between your steth and the heart itself. So that's why you get a decreased muffled heart sound. So a bit of pharmacology. So this is kind of the summary of what you want to treat for each of the conditions. So hypertension, you have high blood pressure. You want to either reduce the total amount of fluid in the body or reduce the resistance of the blood vessels. So these are the drugs that can be used for that. And then angina is when the cardiac muscle is not receiving enough blood. So you either want to increase the amount of blood flow or decrease the cardiac oxygen demand. Heart failure, you either want to increase the cardiac output, reduce the total body fluid, or prevent tachycardia with beta blocker. And then arrhythmias, it will be rate control or rhythm control. So going to more specifics, so ACE inhibitor. So for an example, you have perindopril. It inhibits the ACE enzyme basically. And because, as you remember, so ACE is angiotensin converting enzyme. So if you inhibit this, you inhibit this, and you inhibit aldosterone. So because of that, you get vasodilation and water excretion. So it's used to treat high blood pressure and heart failure. Just remember the buzzword dry cough. For ARBs, it's the same thing, but there's no dry cough, basically. Beta blockers, you have beta 1 selective or non-selective. So it pretty much decreases sympathetic drive to the heart, and it will be used to treat angina, stable heart failure. And contraindications, just if the patient has asthma, don't give beta blockers. So calcium channel blockers, you have the cardioselective, so verapamil, and the peripheral and cardio, so amlodipine or nifedipine. So it decreases contractility because calcium is in charge of contraction of the heart, sorry. And it also vasodilates your blood vessels. So that's why you can use it to treat high blood pressure and angina. So these are all the diuretics as well. So loop diuretics, thiazide, and potassium sparing. I guess the buzzword is just potassium for spironolactone. And then GTNs, so they're just vasodilators. Use them for angina to open up the coronary arteries. So antiarrhythmic drugs, you have either rate controllers, so they either decrease your heart rate, or you have rhythm control, so it actually fixes the rhythm. So these are some of the drugs that we use. So sodium channel blocker, beta blocker, so these are rate controls, and then amiodarone and calcium channel blockers. You also have digoxin, so that's a positive ionotrope, so that increases your cardiac output by increasing the calcium in your body. So this is used to treat AFib. And then amiodarone, you can use it to treat VFib and VTAC. For adenosine, it's a buzzword for treating SVT. I guess at this stage, you probably don't need to know the mechanism of action or anything, just know what it's used to treat for, basically. Lipid-lowering drugs, so just know that statins are for cholesterol, fibrates are for triglycerides, and then this is for both. So triple whammy. Never give NSAIDs, diuretics, and ACE all together. So the reason for this is because your kidneys will pretty much die. So the NSAIDs will constrict your afferent arteriole. So because of that, there'll be less blood going to the kidney. Diuretics decreases the total amount of blood in your body. So there will still be less blood going to your kidneys. And ACE dilates the efferent. And because of that, it also decreases EGFR. So all three of them decrease the amount of blood going to the kidney. So the kidney will go through acute kidney failure, basically. So this is the summary of the treatment. Yeah, so thanks for listening. Do you guys have any questions or anything? All right, if not, I guess good luck for your VIA exams and your OSCEs. And yeah, I might see some of you at Frankston next year. So yeah, if you have any other questions, just message. Oh, hang on.
How's your lecture?
Yeah, all right. Good time. Lots of other Are you heading back now?
Oh, my state.
Thanks for coming down.
It's alright. I emailed it to myself. I changed a little bit.
Oh,
Okay.
good. Is it on a USB or something?
I don't know what your one's work. Can I use
If you don't have a USB, like, are you using the same ones you sent me?
one slightly different?
Oh, okay.
I think it's.
All good.
I just emailed it because I don't. I think it's a really big file. So.
Yeah, probably because it's pretty big. Were you in placement beforehand?
Yeah.
Yeah.
I mean, so the yellow that I go. Is there any internet or no internet?
This does. If you want to try email them.
Yeah, I already emailed it.
Oh, you've already emailed it. So yeah, you can log in.
I just thought there was no internet.
Internet Explorer. Go to Gmail. Is it your Gmail?
Yeah, my students.
Is it in your like Monash email? Just go to Gmail.
Gmail.com.
Just like search up Gmail. Just looking.
Frustrating. Sorry.
See you, man. Yeah, that should be good.
It's too large to preview.
Just open it, yeah. It's pretty
I
big.
don't know why it's so big.
Oh, okay, it's working now.
Is there recording?
Sorry?
Is there recording? Or is it like
Yeah, it's recording.
already? Oh, wow.
Yeah, no, we just let it run.
Sorry, guys. I think I might just pull this out.
If it's not copying to the USB, probably don't need.
Yeah, I might just.
Yeah.
Sorry, I might just say anyway.
All good.
Do I have to speak into
It'll be able to hear you.
Okay. we should start.
Yeah? Whenever you're ready.
Yeah. I think I can make a start now so you guys can leave early. First, thanks for those who stayed back, because I know it's a long day of lectures for you guys. So I'm Jessie, I'm a current third year at NMC, and I'll also be like at Peninsula next year with Will as well. So I'll just go over ECGs, which I think is a pretty important topic. You won't get too much, I guess, for the exam, but it's more for, I guess, later on as you progress through med school and obviously when you become a doctor. So I'll quickly go over the background physiology. I think Will might have covered some already. How to approach an OSCE, some ECGs you have to know, and some previous past exam questions which I've pulled out, which I think the best way to practice is to do previous exam questions. So the ECGs to know for year 2A, I'll cover them all today. So hopefully these should all be pretty familiar already. So references and credits. So a bit of background physiology, I think you guys would already know. So I might just rush over the slide, but basically the current starts at the SO node in the right atrium, and that has the highest level of automaticity, and the intrinsic rate is 60 to 100, and that's why the normal heart rate is 60 to 100. And then it goes down to the AV node, where it's delayed, down to Buttock and the Purkinje fibers. So basically, that becomes important when you have a block at any one of those sites, and the one with, I guess, the highest rate is one that takes over. So that's an important concept to keep in mind. So ECG leads. So the classic ECG leads would be 12 lead ECG, but it's only 10 electrodes, and the reason is just due to some, it's like physics and vectors, so we don't really have to understand exactly. But I think it would be a pretty fair game to have an OSCE on an ECG station, and then involving you maybe put on the leads on a mannequin and then have a printout ECG and then ask you to interpret it. So the limb electrodes, there's 4, so left arm, left leg, right leg, and then the chest electrode position. So it's pretty, one of the things I used to always get confused about was heart auscultation and where to put the chest leads. So the way to remember is when you're auscultating the heart, you're actually listening to where the blood flow is going. So if you remember, the aorta is like on top of the heart. When you auscultate, it's a second intercostal space, so above. And then when you put the chest lead for the ECG, it's on the fourth intercostal space. So important not to get confused in OSCE. So V1 would be fourth intercostal space on the right sternal edge. V2 would be the left sternal edge. And then you go on to V4 first. So fifth intercostal space midclavicular line. And then V3 is between V2 and V4. And V5 anterior axillary, and V6 is mid-axillary. So important to know where the leads go. And also, just an extra side note, you might have heard of some posterior leads, which you don't really have to know, but we sometimes do this when we suspect a posterior AMI, but you don't really have to know, but just in case. So where are the leads? So I'm sure you guys already know all this already. So anterior is V1 to V4, lateral 1 AVL, V5, V6, and inferior is 2, 3 AVF. So you just have to really memorize them. And a good way of, I guess, remembering is actually looking at the ECG slide. So the inferior will, like, it tends to be like the bottom of the ECG, so remember that's inferior. The lateral tends to be on the sides, and the V1 and V4 is anterior. So if you, I guess that's the one way of remembering, and also remembering the axis as well. So how do you approach an OSCE? So there's a lot of ways to do it. This is just one way, mnemonic, if you like mnemonics. There's ICRAM. So always identify the patient, look for previous ECGs, look to see if it's calibrated, look at the rhythm and rate, look at the axis, and the morphology is going through systematically looking for P, PR, QRS, ST, and T wave. And at the last step is interpretation. At year 2A level, most of the marks is just about being systematic and not missing anything. So even if you don't get it quite right, you'll get most of the marks anyway. So don't be too concerned if you can't quite get it. So the first step is identify. So it's always at the top of the ECG, the patient's name, the age, and what they're presented in with, and when it was taken. It's important to note if there's any chest pain the patient's had while taking the ECG, and also important to note if they're on any other cardiac medicine. So that obviously can affect the ECG. So if they're on digoxin, that could affect it. And also things like beta blockers can slow down the heart rate. So if the person comes in with a really low heart rate and wondering why, it could be because of the medication they're on. It's always important to compare previous ECG, so no, it's a new change or it's an old thing. Oh, sorry, I should have asked. This is a pretty, I think, common ECG you might come across. So it's AF. So I've already given away how to identify it, but this is something you definitely have to know. Does everyone feel comfortable with picking up what AF is on the ECG? So it's irregular, regular, no P wave. So that's something you have to know, and it comes across in lots of EMQs. So calibration. So there's 3 things you look for. Otherwise, you can't really interpret the ECG properly. So you have to look at paper speed, which is always at the bottom. Look at a calibration box, which are 2 big boxes on the side. And AVR is negative. And also you have to look, is it baseline or is the patient moving? And there's too many artifacts, because if there's too many artifacts, it would be too difficult to interpret. And I guess there's 2 main things, differentials, if the AVR isn't negative. I don't know if anyone would know. If the AVR was positive, what would you be looking for? Yeah, so if the heart is on the other side, and the most common is actually putting on the wrong lead. So important to keep that in mind. So always check that AVR is negative. All right, so the rhythm. So I'm sure we've all heard of sinus rhythm. So all that means is that P waves is before each QRS and that the impulses start at the SA node. To look at if it's regular or irregular, the easiest way is to get a piece of paper and just mark out each R to R interval and check if it's consistent. If it's regular, then it's just regular. And if it's irregular, it can be split into regularly irregular or irregular irregular. The only difference is that the regular irregular has a pattern to it. So you can predictively know when the next, drop off is, or so that's the only difference. I don't think that's that important, but I always get confused, but that's the main difference. So the rate, to determine the rate, I'm sure you guys already know, but it depends if it's regular or irregular. So it's important to always check if it's regular or irregular first, because if it will determine how you calculate the rate. So for regular rhythm, use a big box method, which I'm sure you've heard of that. So it's 300 divided by the number of large squares between each R to R, or 1,500 divided by the small squares between each R to R. But if it's irregular rhythm, you can't do that. You can just look at 1 10-second strip and just times that by 6. And sometimes you might have a different atrial and ventricular rate and complete heart block, but you can see that later on. And to look at the rate, it's best to look at lead 2. And having that all together, it helps to pull down your differential. So I guess a clinical approach to arrhythmias would be, you want to look at 3 things. Is it fast or slow? Is it regular, irregular? And is the QRS narrow or wide? And once you figure those 3 things out, you can narrow down your differential list. So even if you're not too sure, if you even describe ECG like that, you'll most likely get a diagnosis. So if it's a tachyarrhythmia, it's irregular, there's wide QRS, then you can think maybe it's like VT, which is something that they can ask you to diagnose. So axis. So the proper way to do it is looking at 3 different leads. So using 1 AVF and confirming with lead 2. I'm not sure if you've heard of this one before, but the easiest way to remember is if in normal axis, 1 in AVF and 2 is positive. So positive just means it's R's going more up, and that's normal axis. And in left LAD, it's leaving. So lead 1's positive and AVF is negative. So the leaving or the left axis deviation. In contrast to the right, so it's right axis deviation. So the 2 bits are pointing right at each other or reaching each other. Let's look here, 1 and AVF. Most of the time, I just look at leads 1 and 2, and based on that, you can figure out if it's reaching, it's right. If it's leaving, it's left. If it's 2 up, it's normal axis. And that gets, it's easiest to remember. And it's pretty, and it can be important because there's obviously multiple causes of right axis deviation, left axis deviation. So that's, I guess, something I want to look out for. I'm sure you already know, I should have mentioned previously, but leads tend to, it's positive when it goes, the current goes down in a left and downwards direction. So any of the leads that are positive, it means it's going that direction. Anything that's going away is negative, if that makes sense. That's why AVR is always negative. It's going up and right versus anything going down and left. It should be positive. So this is a bit of an exercise as to how to figure out the axis really quickly. I'm not sure if anyone wants to have a go. And what will the first one be? So you got 1 that's negative, and then 2 is positive. So they so I've got the answers here anyway. So if you look at 1 is going down, the 2 is going up, so like they're reaching each other. So that's right axis deviation. Normal axis, 1 and 2 are both more positive, and left axis is 1 is going up, 2 is going down, so leaving each other. So that's left axis deviation. So that's the easiest way to look at it. So you won't ever forget. All right, this is a bit. Okay, now looking at each bit of the PQRS morphology. So we know P wave is when the atrial depolarizes, and that's just the normal morphology. I guess the 2 main things to look out for is P pulmonale, which means right atrial enlargement, and then P mitrale, which is mitral stenosis. So the easiest way to remember P mitrale, because it's P M for mitrale, looks like an M. The P looks like an M, and that's due to mitral stenosis usually. That's why it's mitrale, if that makes sense. So you know, remember, if it's P mitrale, it's left atrial enlargement. And then the PR interval. So the normal PR interval is 3 to 5 small squares. And the main thing we'll look out for is that decreased or increased. So if it's decreased, it's most likely going to be Wolff-Parkinson-White syndrome. And I'll go into that later, but you look for a delta wave. If it's increased, it could be any of the AV block heart blocks. So first degree is just prolonged PR interval. And then second degree, there's 2 types. Type 1 is Wenke back. So it's gradual prolongation of the PR interval until there's a non-conductive P wave. Whilst in second degree type 2, there's intermittently non-conductive P waves, but the PR is fixed. And then the third degree, there's no relation between the P and QRS. So they're completely independent of one another. The Q wave. So the main thing to look for the Q wave is that you're going to look for a dip. So any deep Q waves suggest an old myocardial infarction. So a normal Q wave should be very small, as you can see here. Should be less than a quarter of the QRS complex. Anything more than that, you're thinking that had a previous myocardial infarct. And it's also important to know that for someone who presents with a STEMI, the ECG changes depending on when you've actually taken the ECG. So in an acute setting, we always look for an ST elevation, but in the long term, the Q wave can persist, and days later, or even long term, the T wave can be inverted. So that's a sign of ongoing ischemia as well. So then QRS. So the normal cutoff for QRS is less than 3 small squares, which is the same as 0.12 seconds. The way I remember is QRS is 3 letters, so less than 3 small squares. Another easy way to remember it. So basically, if it's narrow QRS and you're thinking it's something from the atria or supraventricular above the ventricles, anything broad, you're thinking the problem's in the ventricles. And also, if it's broad, you want to look out for changes of right bundle branch block and left bundle branch block, which I'll go into later as well. And then the ST segment, which we've all heard about for AMI. So if it's ST elevation, you're thinking infarction, so actual death of tissue. I think Will went over the pathogens. And ST depression is ischemia. So infarction is actual death, and ischemia is just lack of oxygen. So that's the main difference between elevation and depression. And the elevation has to be in 2 or more contiguous leads. So contiguous just means within the same region. So 2, 3 AVF would be contiguous because they're all resembling inferior. And another thing to look out for is pericarditis, when the ST elevation is widespread and saddle-shaped. That's important to look out for. So when you're looking at ECG, don't just look, oh, there's SC elevation there, interstemming, and you look around the whole ECG, because if it's in more than one area, you're thinking it may be more likely to be pericarditis. And then for each location of the SC elevation, it corresponds to a coronary artery, so that's pretty important. I think they tend to ask that as well in exams. And also another thing to look out for that can help aid your diagnosis is looking for reciprocal SC depression. So for example, in inferior lead, so you see ST elevation, you'd also expect ST depression on like the opposite, so in the lateral lead. That makes sense. So that's important to also help with your diagnosis. And then the T wave. So this is the repolarization of the ventricles. So I guess the big buzzwordy thing is the reverse tick or downward sloping for digoxin toxicity. If the T wave is inverted, as I mentioned previously, it suggests ischemia. If it's peaked, a really big peak T wave, you're thinking hyperkalemia. If it's really flat, you think opposite, it's hypokalemia. And if there's a little U wave, it could mean delayed repolarization of Purkinje fibers, but that's not really clinically significant, and the presence or absence of that doesn't really change them. Doesn't actually mean there's something wrong. There's something to add. So the ECG patterns. So we all should know what normal sinus rhythm is. So upright P waves, constant PR, regular narrow complex, heart rate is 60 to 100. And then there's different sinus rhythms. So sinus tachy when a heart rate is more than 100. I guess the main thing to look out for is that sometimes if it's really fast rhythm, the T wave and the P wave can come together, so it might be tricky to look out for. Sinus brady, just heart rate less than 60. And sinus arrhythmia is just sinus, but it's in a regular rhythm. And that's actually quite normal with inspiration, expiration. So rate increases with inspiration is one way to remember it. So AF, as I mentioned previously, so this is very important to be able to pick up. So it's irregular, regular rhythm, no P waves, and the symptoms could be palpitations, exercise intolerance, and some chest pain. I think Will's gone over the treatment, but weight control, there's three main principles, so rate control, rhythm control, and anticoagulation. So the way to remember rate control is like B, C, D. So beta blocker, calcium channel blocker, or digoxin. Those are your drugs. And the rhythm control, in terms of drugs, will be Solor, amiodarone, and flecainide. The anticoagulant depends on Chad's vascular, which I don't think you guys have to know yet. But the main reason is that in AF, the main complication is stroke. So when the atria isn't beating properly, it fibrillates, and then that allows blood to pool and allows it to clot. And if the clot goes up, your internal carotid goes up to your brain. So that's why we worry about anticoagulation. And then there's also surgery option, which you don't really have to know, but another option if it's refractory to medical treatment. So atrial flutter. So the main thing to look out for is a saw tooth pattern, which is pretty characteristic. And the atrial rate is always subdivided by 300, if that makes sense. So it can be 2 to 1, 150, 3 to 1, 100, or it can be variable block as well. The treatment is the same as atrial fibrillation, but it obviously looks quite different on the ECG. So the main thing is sawtooth pattern, and the rate is divided by 300. And then there's SVT. So it's tachy, it's now QRS, and it's regular. Again, the symptoms are pretty similar. The main treatment would be Valsalva maneuver to reduce the heart rate. And I think they might have asked this previously, but how do you treat SVT? The answer is adenosine. Not sure if you guys heard much about adenosine, but it gives a sense of impending doom. So that's another thing to look out for as well. If they mention that, it's probably due to adenosine. And then there's Wolff-Parkinson-White. So that's when the PO interval is less than 3 small squares, and there's delta wave. So what I remember is that it's like a little D, like delta, like that delta. And that's due to the slow rise initial part of QRS. It can be QRS prolongation. And I guess the main thing to look out for is due to the bundle of Kent. So one option is to surgically ablate that. And then there's ventricular tachycardia. So its tachycardia is more than 100 beats per minute. It's broad QRS, so you know it's in the ventricle. And important thing to know clinically is that it's one of the shockable rhythms. So there's two main shockable rhythms when you do like basic life support. So will you put your hand up?
Yeah.
Sorry, I didn't notice you.
So for SVT and sinus tachycardia, how would you tell the difference?
So if you look at here, there's actually, can you see a P wave here or not? Yeah, so there's actually no P wave in SVT, which is one way of distinguishing it between a sinus tachycardia. There's no P wave because I'm not sure exact physiology, but I remember my clinical tutor also said that. That's one way of differentiate because they're both regular, narrow complex tachycardia. Main thing to look at is there a P wave. If it's P wave, it's from the SA node, so it's sinus. If it's not, then it's not sinus tachycardia, it's SVT. Because SVT is like a really broad term for any tachycardia above the ventricle, so the atrium. So that's the main way to differentiate it, is that P wave that's missing. That's a good question because, yeah, it's tricky. Okay, ventricular tachycardia. So it could be monomorphic, which is the one seen here, or polymorphic. The main polymorphic one you want to look out for is torsade de pointe, not sure if I pronounced it right, where there's very, very amplitude of QRS and prolonged QT. And the management for that is magnesium sulfate. I think they might ask that question as well, like how would you manage torsade de pointe? It's magnesium sulfate. And the other shockable rhythm is ventricular fibrillation. So it just looks like a big squiggle and there's no pattern to it. And it's important to know because it's the most frequent cause of sudden cardiac death post-AMI. And the way to differentiate between torsade de pointe and VF, because they both look squiggly and irregular, in this scenario, VF will always be unconscious because that's not able, I guess, to sustain enough cardiac output to remain conscious, to retain consciousness. But torsade de pointe and VT, the patient's usually conscious. So that's one way of differentiating the two. And this is the one you do CPR. So different types of heart block. So the first degree is pretty simple. So just PR greater than 5 small squares, and there's one-to-one relationship between P and QRS. Second degree, also known as Wenke-Back. So is when there's prolongation of the PR interval and then a sudden drop off the QRS complex. And this is like a first degree AV block, it's usually quite benign. Then a second degree type 2. So then there's non-conducting P waves without prolongation of the PR interval. This is more serious condition than second degree type 1. And in these patients, you have to consider if they need an implanted pacemaker. And then this third degree heart block. So when the atria, the P waves march through independent of the QRS. So the way you figure that out is if you measure the P to P, it's regular and it goes through. So regular P to P intervals, and then R to R is regular as well and unrelated to one another. And this is very important because in these patients, the only way to definitively manage them is giving them a pacemaker. Otherwise, the heart rate is going to be too low. And then there's pericarditis, as I mentioned. So this is when there's widespread ST elevation and PR depression, and that's throughout most of the leads. So as you can see here, there's like in 1, 2, AVL, and the anterior leads as well. So in that case, you're thinking pericarditis rather than a STEMI. And there's also PR depression as well throughout most of the leads. I think Will already went through how it presents, and the treatment will be culture seed NSAIDs to reduce the inflammation. And then STEMI and non-STEMI, I think they went through this already. But basically, in terms of ECGs, the main thing we want to look out for is the NSTEMI or STEMI, more importantly STEMI. And that falls under a broad umbrella of syndromes called acute coronary syndromes. And the way to differentiate between stable angina and acute coronary syndromes is patient history. So with acute coronary syndrome, tends to be sudden. The pain is still there at rest. The patient doesn't get any relief with GT under the tongue. That's where we get really worried. And then to differentiate unstable angina, NSTEMI, and STEMI, you look at troponins and the ECG. The unstable angina, there's no change in ECG and there's no troponin rise. NSTEMI and STEMI, they both have troponin rise, and only NSTEMI has ST elevation, and NSTEMI has obviously no ST elevation. So inferior STEMI, so that's when there's elevation 2, 3 AVF. So this is a 2, 3 AVF, and it's also reciprocal ST depression in AVL and 1. So it's a bit there and AVL as well. So you can see that together is consistent with inferior STEMI. Most of the occlusion for inferior is a right coronary artery, so that's important to know as well. And anterior is V1 to V4, and that tends to be caused by left anterior descending. Lateral STEMI is AVL 1, V5, V6. And that's due to left circumflex usually. Important to know what arteries, because they sometimes might ask that as a question. And then posterior STEMI, that's unlikely to come up, especially with a 12-lead ECG. The main thing I want to look out for is a reciprocal ST depression in V1 to V3. So V1, V3, remember, is anterior. So anterior is opposite of posterior, so that's why there's reciprocal depression in these leads. And then the bundle branch blocks. So this is something you want to look out for if there's a broad QRS. So there's a mnemonic, William Marrow. I'm not sure if you guys heard it before. But William is for left bundle branch block. So the first letter corresponds to V1. The last letter corresponds to V6. And the letters in between tell you if it's left or right. So for William, V1 looks like a W and V6 looks like an M. So that's a left bundle branch block. And then for right bundle branch block, it's Marrow. So in V1, it looks like an M. V6 looks like a W, and it's Marrow, so it's right bundle branch block. It's a good way to remember it, but in reality, sometimes we look at ECG, it's tricky to know if it looks like an M or a W. So the way I remember it is basically with a left bundle branch block, there's a big S wave in V1, and in right bundle branch block, there's an RSR in V1. That's how I remember it. But I guess this mnemonic can help you as well. And the reason why we look at V1 and V6, so V1 is on the right side of the heart. So normally that should be going down. And V6 is looking at the left side of the heart. So with left bundle branch block, because it's V1 looking at the right side, it should be negative. And it's because it's left, it's like very deep S. And in right bundle branch block, so the V1's looking at the right side, so it gets positive, which normally is negative. So you know it's right bundle branch block is going there slower. And it has this RSR because normally the right and left ventricles, they contract together at the same time, or the current goes at the same time. But when there's a bundle branch block, there's the left side going before the right side. So that gives us RSR. Also important to know that left bundle branch block is more associated with pathology. So one of the diagnostic criteria for thrombolysis and like acute coronary syndrome would be a new left bundle branch block. So if someone comes with a left bundle branch block that's new, you'll be more worried. But right bundle branch block can be present with people who have no heart disease. So that was a lot of information. So I actually made a bit of a summary as well, which I made last year for the OSCE. So you go through how to introduce yourself, general inspection, the process, and each bit of the ECG. And I think you've uploaded that as well later. Yeah. So that's a bit of a summary of everything. So it's a bit easier than going through all the slides. So it basically covers what I went through. The other things which I did include before, sorry, but this is more for next year, but other buzzwordy things. I don't think it'll come up for you guys, but if it's alternate QRS complex, like a high and a low one, that's cardiac tamponade, causes of cardiac arrest, the H's and T's, cardiac arrest, shock rhythms, non-shock rhythms, and PE, which I'll upload the new slides later on. But I don't think you guys have to know, but definitely next year. You can add this to your next year. So past exam questions, those are, I think, the main way of preparing for exams is going through the questions. And some answers may not be correct, but we can go through it together. So, the first one is a pretty easy question. So this is just testing your basic knowledge. So what does each small square represent in seconds? This is like pretty basic stuff. 0. Yeah, and what's the heart rate? So how would you calculate the heart rate? Because you can use a big box method or the small box method. All right, I might just go through. So, so each small square, is 0.04 seconds. So just something you have to know. And the heart rate, because it's a regular rhythm, you can use a box method. I use the big, using little boxes, so it's 1,500 divided by, if you count, like 22, so it's about 70 beats per minute. So they might ask you a question on that, but it should be pretty straightforward. So next question. Alice is a 20-year-old secretary, presents to GP with intermittent left-sided prickling chest pain for 1 day. She also has trouble breathing and is feeling dizzy. Yeah, so ECG was done. What does it show? Does anyone think they might know? So I actually thought this was a tricky question, but at the end, I think it's a normal ECG. And I'm not sure if you guys can think of any pathology, but I couldn't pick up anything that looked too abnormal. Do you guys think anything different? Like, there's no myocardial infarction. I can't see any significant ST elevation. It's not AF, it's regular. There's no sawtooth pattern. The PR doesn't look prolonged. The axis is normal. There's no BQRS, so it's not a bundle branch block. So, and the rate is it's between 60 and 100. So I think it's a normal ECG, and I checked some previous students' answers, and I thought the same. So I'm not sure if you guys would agree. And also some clues. So it's a young female, and it's left side prickling chest pain. So it doesn't sound very ischemic. Ischemic chest pain tends to be like crushing central, radiates the jaw down the arm. So I think this is more the Alice was just feeling a bit anxious. I don't know if you guys agree or disagree, but I couldn't find any pathology unless any of you guys can find anything. But so next question. So Hassan Abdullah is a 60-year-old man who complains of chest pain after a traffic accident. He has diabetes and history of hypertension. ECG was done for him. What does it show? So I think the answer is left axis deviation. So if you remember looking at leads 1 and 2, they're leaving each other, so it's left axis deviation. Also, another hint is that the patient is hypertensive. So left ventricular hypertrophy can also cause left axis deviation as well. So that's another hint. Even if you weren't sure about ECG, if you read the scenario, it sort of makes sense. So next question. Susan has an episode of epigastric discomfort. So the ECG changes consistent with acute inferior myocardial infarction. Which leads would you find these changes? With A, yeah, this one's pretty easy. So you just have to remember 2-3 AVF is inferior, 1 AVL V5 V6 is lateral, and V3 or V4 is anterior. So that's just something you have to know. This is an old exam. I don't think this will come up, but where is electrical conduction in the heart normally initiated? SA node. And which part of the conduction system is the slowest? AV? Yeah, easy. So SA and AV node. Pretty easy. So next question. Joe's ECG showed complete heart block, consistent with ischemia affecting the AV node. Which of the vessels is most likely to be occluded? So if you remember, the conduction system is usually supplied by the right coronary artery. So I thought the answer was origin, the right coronary artery. And then the marginal branch will supply more of the right ventricle, which is a bit too distal, which is a bit too below the AV node. So the right coronary artery. I don't think you guys, this will come up, but I don't think, because everything's MCQ now, but I guess the main thing to not get confused is the PR interval is different to the PR segment. So just be aware of that. And the PR starts at the beginning of the P and beginning of the QRS. So just don't get confused between those two. But I don't think they'll ask you to label ECG, but it was just a very, very old question I found. So this is pretty easy. So which of the conditions is associated with an absence of a P wave? I think you guys are saying the right answer. So it's AF. This is a repeat question. I saw when I was going through Equala, the past exams, I think I asked this more than once. So definitely remember, no P wave, it's AF. Okay, so just remember that. That's an important condition as well. It's pretty common. So next question. So Vivian is a 60-year-old female, presents to ED with chest pain, shortness of breath, and palpitations. What does her ECG show? So can anyone describe it? So I thought it was ventricular tachycardia. Reason being is that it's regular, so it's not like a ventricular fibrillation or AF, and it's also broad complex. So if it's broad complex, you think it's coming from the ventricles. So it's likely to be ventricular tachycardia, and that's something I think it would be reasonable for them to put up as well. Next question. So 50-year-old man, past history of diabetes, presents with palpitations. The pulse is irregularly irregular. Which of the most likely findings of the P wave is on his ECG? Yeah, it's absent. So, but like asking this a lot. So definitely remember that. Next question. This is a bit trickier. So Fiona is a 60-year-old female, history of gallstones, presents to ED with severe epigastric pain that goes to her right scapula. So do an ECG for an ED. What does her ECG show? This one's hard. So all the options are about myocardial infarction. So is it acute or is it old? Um, so I think the answer is old inferior myocardial infarction. So if you look at the inferior leads, 2, 3 AVF, you can see there's like this Q wave which like dips down, and there's also T wave inversion as well. So those two signs are indicative of previous ischemia. So I think the most likely answer is old inferior myocardial infarction. And I think the rest of the scenario is just unrelated, like not a current presentation. The next question. So what's the most likely diagnosis from this ECG? So I think the answer is first degree AV block, because there's a prolonged PR interval. It's fixed and there's P before each QRS. There's no non-conducting P waves or drop QRS for like a second degree heart block. So I think most likely it's first degree AV. There's another question. So sometimes I think just like to ask what's the width of each small square, large square, and what the heart rate is. So it's a bit repetitive. Sorry. Yeah, so the small square again, 0.04. The large square is that times 5, so 0.2. And then the heart rate, you just have to count the amount of squares in between each R to R. So if you use the big box method, it's 300 divided by 3.6, which is about 85. The next question. Mike is a 65-year-old male with OA, requiring a knee replacement surgery. As part of the pre-op workup, his ECG is taken. What does his ECG show? I think answer is left axis deviation. Again, 1 and 2 are leaving, so it's left axis. And you confirm it looking at AVF. There's no ST, like significant ST elevation. It's regular, and AVR is negative, so it's not dextrocardia. So I think they like asking left axis deviation quite a lot. Next question. Mark is a 65 female, presents with dizziness. When taking her vital signs, her pulse rate is very low, and so an ECG was done on her. What does her ECG show? So I think the answer is second degree type 2. Because third degree, you'd expect complete dissociation. It's not AF because P waves are present. In first degree AV block, there'd be a prolonged PR, but a 1-to-1 ratio of QRS, but there's some non-conducting ones, so it's not that. And then second degree type 1, there'd be progressive prolongation of PR. But the PR, if you count, it's the same. So it's second degree type 2. Another important thing is to know terminology. There's for AV blocks is degree, first, second, third degree, and the types are only for second degree. It's important not to get that mixed up. I think that's about it. Is there any questions? So it was really quick. Yeah.
Thank you.
Huh?
Well done.
Oh no.
Thanks heaps for coming, guys, and best of luck for exams.
Oh, do you want me to? Do you want this version?
Was that version slightly different?
Yeah, it was.
Do you just want to forward the email you sent to yourself today? I'll give you
What's
my
your
email.
email?
That might be a bit easier.
Can I do that?
Yeah.
It's too big to.
Yeah, it's kind of too big to put on
Even
the
uploading it on Google via text from.
I'll just put my email in. Yeah, that should be good. And then I'll just log you out.
Yeah, of course.
Do you ever get stations where you actually have to put on the
Some post-grad. So last week we did have practice this week where, like,
I've never seen an ECG machine.
because I was in the church classes and they did actually do practice stuff. So we have a patient there, we put the arm leads on and the leg leads. And then there's like a fake mannequin thing. We put all the chest leads on and afterwards